Okay. Um, yeah, so today is just a very exciting day because for me, as a Region 6 chair, I get to welcome you and announce the wonderful speakers who are here today to share their advice on how we, as aspiring psychiatrists, can do better for our patients. So, with that being said, I'm very proud that the theme this year is psychiatry in the time of COVID-19, as I believe that we need to be talking and reflecting on how the field of psychiatry has been affected and how we can move forward as providers. So, as medical students, I know we faced a lot of challenges from this pandemic alone, from starting school or rotations in the midst of a pandemic, only to be communicating with others through a screen, to dealing with daily COVID checks and maybe even witnessing loved ones pass away and everything in between. I know that COVID has really permeated all aspects of our lives. And I don't say this to be pessimistic or to put a downer on anything, but I say this to speak on how we have all been working to create a new normal for ourselves in this unprecedented time. So, particularly in the field of psychiatry alone, there have been many challenges that providers have faced in patient care. So, my hope for this conference is that we can take away new perspectives on how to improve patient care, particularly in the pandemic. So, with that being said, and before we begin our first talk with our keynote speaker, I would like to thank a few very important people. I would like to thank the speakers here today that we'll be having Dr. McCarron, Dr. Moffic, Dr. Wang, and Dr. Starks for taking out their time in their busy schedules to be here and share their wisdom with us. In addition, I would like to thank those who helped in making today happen Sean Woodward, Jennifer Puthada, Isaac Mitchell, Pooja Vora, Jennifer Lai, Ivan Lee, Meg Chakarian, and Maximilian Lee. With that being said, I would like to introduce our keynote speaker, Dr. Robert McCarron. Dr. McCarron is truly impressive. He completed his residency in internal medicine and psychiatry at Rush University and received his board certification in psychiatry, psychosomatic medicine, and internal medicine. He started the only two California based combined internal medicine and psychiatry residence programs while he was on faculty at UC Davis and created a med psych curriculum that is still used in the public health mental health system by psychiatry residency programs. He has either had or still has all sorts of titles from being the director of the only Sacramento Crisis Stabilization Unit, founding director of the UC Davis Train New Trainers Primary Care Fellowship, professor and assistant dean of the Department of Psychiatry and Behavioral Medicine at UCI, and president of multiple different psychiatric societies and organizations. Ooh, that's a mouthful. So, a lot of titles. And an impressive psychiatrist. So, on top of that, Dr. McCarron has numerous publications in the areas of medical education and psychiatry. And as Dr. McCarron clearly has years of experience and expertise in this field, we are very lucky to have him with us today. So, without further ado, our keynote speaker, Dr. McCarron, I think he should be here. I'm not sure. Let me try to get a hold of him. Well, I'm going to get a hold of him. Thank you, everybody. He was just here. Let's see. Sorry, everybody. There might have been some tech stuff. Let me try to get a hold of Dr. McCarron as he was just here. Oh, and there he is.
Good morning again.
Good morning, Dr. McCarron. I just wanted to ask you in advance, is it okay if we record this talk right here?
No, that's fine. Yeah.
Okay, awesome. So let me give you, I'm not sure if you have the co-host capabilities again.
I don't.
Okay, so let me give that to you right here. But I had just introduced you. So with that, if you don't mind just taking it away then.
Sure. Let me share the screen here.
Thank
Guys.
you.
There we go. Can you see that okay?
Yes. Thank you.
Well, so good morning, everyone. My name is Robert. I work at UCI. Do we have anyone from UCI on, by the way? No one from UCI in the house. Okay, so we have a relatively small group this morning, so I just want to see, know who you guys are a little bit, if that's okay. Can we take a couple minutes and do that? Okay. So why don't you guys just start? Whoever wants to start, tell me who you are, where you're from, are you interested in psychiatry, and what do you want to know from this talk? How's that? Because I have my slides right here. There's stuff I can tell you, but I want to know what you guys would want to know. So who should we start with? Kwan, should we start with you?
Oh, hello. Hi, I am a first year medical student at UCI. My name is Kwan and I'm interested in psychiatry, so happy to be here.
Oh, good. Hi, Kwan. Good to see you. Good to see you. How's UCI doing so far? Are you doing okay?
Yeah, I am. Thank you. Just adjusting to coursework and everything.
It's an okay place. The professors, they're so, so. All right. Well, it's good to see you. Grace, are you there?
Hi, good morning.
Morning.
I can go. I'm Pooja. I'm a third year medical student at Western. I'm also interested in psych and possibly even med psych, so I'm super excited.
Oh, med psych, really? I'm just kidding. I did med psych. Joke. Med psych's pretty fun. There's a lot of cool stuff that you can do with med psych. And Meg?
Hello, I'm also from Western U and I'm interested in psychiatry and I would like to know more about this field.
Great. All right, Jennifer?
Hi, I'm also from Western, also a second year from Western, and I'm also super interested in psychiatry, and also just learning more about how like the burnout and COVID has impacted. So that's why I'm here.
Great, thank you. Ivan?
Hi, I'm Ivan. I'm also a second year from Western University of Health Sciences. I am actually very interested in psychiatry, and I recently kind of got more interested in the field of consult liaison. So I'm actually really interested to see kind of how this kind of intersection between like medicine and psychiatry really kind of manifests itself in kind of different patient populations.
Great. Okay. Well, thanks for being here. I see, Isaac, you're from Loma Linda.
Yes, I'm a fourth year from Loma Linda, applying to psychiatry right now. Yeah, I know COVID has impacted psychiatry in a lot of ways, especially with telehealth, but I just want to learn more about what it's done to kind of change the trajectory of our practice.
Yeah. By the way, how are interviews and stuff going for you?
Going well. Yeah, things are busy, but yeah, it'll be nice when this season is over.
Yeah. Well, back in the day, just a few years ago, interviews were a lot more hectic because it was in person. So you'd have to pay for all the travel costs and arrange your travel, and take more time off from rotations, and it was a little more tricky. So I'm glad things are going well. And then anyone else want to introduce themselves? You don't need to, but just give you the opportunity.
Yeah, I'll introduce myself. I kind of gave a little introduction earlier, but I'm Danvi. I'm a third year at Western University, and I am also very interested in psychiatry, particularly in this talk alone. I know that the fields of psychiatry or residency, everything has been changing so much within the past few years. So it'd be good to see your thoughts on where you see us as practitioners or just like young psychiatrists
Yeah.
going. Yeah.
And Danny, thanks for organizing this. By the way, a lot of folks from Western, did you know that the provost of your university is a psychiatrist, Dave Barron, good friend of mine? Yeah. And the former president of Western was also a psychiatrist. I don't know the current psychiatrist. Okay, so let's jump into it. So psychiatry, we talked a little bit about where we're at today, and then, thinking about where it's going. And I'll spend some time on that, and then, kind of talking about why psychiatry, and then, how do you do psychiatry? And then I know you guys have a busy morning, so I might give you just end a few minutes early for questions and for you to, catch your breath. So psychiatry, gosh, it's interesting. COVID had a lot to the field of psychiatry and medicine in general. A couple clear observations. Number one, we see more folks who are struggling psychiatrically or emotionally, particularly when it comes to two things. One is anxiety, and the second is depression. I have seen many, many more 20 and early 30-year-old folks struggling with identity. I lost my job. I got another one. I lost my second job. I'm depressed. I'm anxious. I'm having thoughts of, low self-worth. And this was at the height of COVID. We saw a huge, huge influx of folks who have had no past psychiatric history now struggling with depression and anxiety for the most part. I also saw a bunch of folks who were given, Solumedrol or high dose steroids, even PO steroids, with COVID symptoms in the ER, sent home and became psychotic. So a couple of residents from UCI and I wrote an article on steroid-induced psychosis right at the beginning of COVID. So that's in Current Psychiatry, Journal of Current Psychiatry, and that was about maybe 2 years ago. But it was interesting to see, so many folks coming in with steroid-related psychiatric symptoms. Now, that included psychosis, but it also included depression and anxiety. So that's something we had to look out for. I had one guy, for example, who I saw, and this guy was, he's went to church on a regular basis. His 3 kids, a really good family man, very involved in his church, read the Bible every day with his family, strict believer in, having dinner at home, even with busy schedules. He's a physician and just a great guy, very involved in his community, a lot of volunteerism. And so he got COVID and he got some symptoms, respiratory symptoms. And so he went to the emergency room and got some high dose steroids and then some steroids for the road. And they were told to monitor his symptoms. Within 24 hours, he started calling a lot of the pastors in local churches that he had known and told them that the devil is king, and started taking a permanent marker and writing on his walls at home, that same thing, and listing names of demons and things like that, and denouncing his faith in a very strong way and very publicly. And so we stopped the steroids and gave him a little bit of antipsychotic medication for a short while, and he improved within 3 or 4 days. I'll show you some data a little bit later that shows that we've seen in adolescence and pre-adolescence that the COVID has really created a huge problem, and we know this because of the time that many kids were away from school. Now, this includes even like preschoolers and kindergartners and first graders who usually during those years learn how to line up. They learn how to get into a line. They learn how to raise their hand in class. They learn how to use the bathroom at school. I mean, simple things like that. And now they're, you know, coming back to school and they don't know those things. And so, and there's a cascade effect. The cascade effect, and we'll talk more about this in a little bit, is teachers. Teachers are struggling now. Teachers are struggling. What do I do? How do I deal with this? I've never dealt with this. I'm a preschool teacher. I'm a kindergarten teacher, first grade teacher, and I've never seen anything like this. You know, the kids aren't behaving. They don't know what to do, and so fear was an issue, right? So many folks were fearful, which caused a lot of anxiety. And now we're dealing with the uncertainty, right? Where does this go? Is there going to be another variant? Do I need to get my booster? Do I still need to wear my mask? A lot of parents now are struggling with, do I get my kid vaccinated in California? Do I go along with that mandate? And it's really causing a lot of anxiety. We see less of the isolation now, right? More people are back at the NFL football games or concerts, you know, restaurants, etc. So we have less of the isolation, which was problematic, but ongoing uncertainty. And I would say that from a population health standpoint, we're in a state of unknown, in a state of angst when it comes to this pandemic. Again, we have the isolation part taken away, which is good, but still a problem. And of course, you all know that, you know, we rapidly transformed to doing telemedicine. For some that was difficult. For some patients that was difficult. At UC Irvine, we're still doing about 50% telemedicine and 50% in person. And I think that's here to stay. I think that that's going to be a sort of a customer service option for some patients in some disciplines, probably not primary care routinely, but certainly, you know, psychiatric visits. My guess is that we'll see this ongoing. And in fact, there's something called asynchronous telepsychiatry, which is where the patient will come in to the primary care office and meet with a particular individual who's not a provider, but someone who's some training in how to do a cursory interview. And that person will ask specific questions of the patient. That session will be recorded and at the convenience of the psychiatrist, reviewed at a later time. And when it's reviewed, the psychiatrist will also have a summary from that person who's doing the interview and access to the EMR, and we'll be able to make suggestions or recommendations. And that's asynchronous telepsychiatry. I think we're moving into that. A few articles published fairly recently showing that there's efficacy in that area. I think we'll also do a lot more of what we call collaborative care. You guys familiar with what collaborative care is? So collaborative care is an evidence-based, now standard of care approach in psychiatry where you have a sort of a team-based approach. Primary care provider will send a referral to the care manager, who's usually a nurse or maybe a social worker. The care manager will contact the patient, ask some questions, do a PHQ-9, which measures depression, and maybe a GAD-7, which measures anxiety, and then give that information to the psychiatrist, and they discuss it once a week, and they discuss the patient. The psychiatrist does not see the patient, and then recommendations are provided to the primary care provider. This is a billable service. It's evidence-based. It's, again, now standard of care in the field of psychiatry. So that's a quick summary of how COVID, I think, has really affected us. And again, I think it's not over from a system standpoint. I think we have a long ways to go, similar to the influenza pandemic, which lasted not months, but years. I think that this is going to be a lot different, though, because these variants are lingering on into the summer and the spring, right? Whereas influenza kind of poops out after winter or early spring. And we also see that, of course, influenza is, sort of changes on an annual basis, whereas COVID, SARS changes whenever it wants to change. And so it's been tricky. And before I go on and talk a little bit more about psychiatry and other areas, any thoughts or anything to add or questions about COVID and that you might have? One of the questions that Henry brought up is, are collaborative care and integrative care similar? So there's integrate ed care, which is when integrated psychiatric care, which includes collaborative care, telepsychiatry, it includes asynchronous telepsychiatry, and it includes what we call embedded psychiatry, which means in a primary care setting, you'd have a psychiatrist there or behavioral health person, and of course primary care. So integrated care includes a bunch of stuff. One of those things is collaborative care. Integrative care is different. Integrative care is when we're really trying to treat the whole body, the whole person, and using different approaches of care. So any questions on sort of COVID or even your experiences or things that you would want me to cover when it comes to COVID in general, or kind of where we're at and where we're going in cases?
Has the transition to telepsychiatry, like the asynchronous care, had any effect on overhead costs of care for patients?
No, it hasn't had a change in cost, and in many areas, except for surgical specialties for a brief time, in many areas in medicine, we've seen a surge in business. So we have not seen a drop in revenue. Changes in cost are the same for telemedicine and in person. There's no delta there. So because time is time, and the psychiatrist is spending that time. So good question. Any other thoughts or questions on this?
There's a question in the chat.
Let me take a look here.
I can read it.
What do you perceive as the strengths and limitations of telepsychiatry? Well, I think the strengths are convenience, and it's really good during pandemics. The drawbacks are, you're not able to see as much as you want to see. So for example, if someone has a leg tic or an arm tic, or you're going to miss out on certain things. You can't do a physical exam over the phone. So if you think someone has EPS, you can't check for EPS over the phone. It's hard to do. I mean, I've done it, but it's challenging. And I think in person is just better overall, because you can see the entire patient. But remember, there's a lot of parts of psychiatry these days where you're not really seeing the patient. You're not even talking to the patient, right? And an example of that is collaborative care, where you're getting collateral information on the patient and then making recommendations. So I think the strengths are allows flexibility for patients, allows flexibility for the providers, but it's not entirely ideal, I would say. Good question. So if you have any other thoughts about COVID or questions, let me know. I will also say that psychiatry today and tomorrow is going to be similar to psychiatry of the past. And let me explain what I mean by that. I think what we see in psychiatry is this, and this is an important part of what I'm going to be telling you this morning. There is so much in psychiatry that we just don't know. Just don't know. Absolutely don't know. I'm also an internal medicine doc, and as an internist, there's a lot we kind of do know. There's some we don't know in medicine, obviously, but there's a lot we know. So if someone has a UTI, we pretty much know how to treat it effectively. And the reason we know how to treat it effectively, does anyone know why we know how to treat it effectively? Why do we know how to treat it effectively, a UTI?
because we can probably do a culture and see what kind of bacteria it is and therefore give the antibiotics for it, or there's just
Yeah. Yeah. Why do we know that how to treat strep throat effectively? Any idea? Strep throat.
We also know how strep throat affects us.
How do we know how strep throat affects us?
We know the physiology of it.
We know the physiology of it, right? We know what strep is, and we know what strep does, and we know how to kill strep, right? We know that. We know that most essential hypertension can be treated with calcium channel blockers, ACE inhibitors, ARBs. We know that. And we know the mechanism in which that works. We know the mechanism because we may not know what causes the hypertension, but we know the physiology or the mechanism of pathophysiology behind hypertension. So those are just a couple examples, right? I will tell you this. The psychiatry of today is similar to the psychiatry of 20, 30 years ago, and probably into the future, at least another couple decades. And that is the unknown. It's hard to treat schizophrenia. It's hard to treat people who have schizophrenia. Does anyone know why it's hard to treat people with schizophrenia? There's no cure for schizophrenia. It's hard to treat those symptoms. Anyone know why? Anyone want to take a guess?
Because we don't know exactly what the pathophysiology is of it.
We don't know what causes schizophrenia. No clue. Absolutely no clue. If someone comes in with depression, major depressive disorder, and you treat them with an antidepressant, you'll find that half of the time that antidepressant doesn't work. It just doesn't work. Just doesn't work. And of course, the reason behind that is we don't know the pathophysiology behind major depressive disorder. We don't know the pathophysiology behind bipolar disorder or generalized anxiety disorder, or PTSD. We just don't know. Now you might say, well, we have medications. Well, we do. We have medications. Taking a stab in the dark. We don't know. We don't know what's causing these conditions. And because we don't know what's causing them, it just makes sense that we probably don't have the best treatments. We just don't. There's a lot of people who are in state hospitals. There's a lot of people who are struggling with bipolar disorder. I'm going into the hospital in about an hour to see a whole bunch of patients in our inpatient units at UCI who are struggling for many, many years. Some of those patients have been in that unit for months. Not only do we not have a cure, but we don't have treatments that are going to routinely or reliably treat those symptoms, unfortunately. And so psychiatry is in a kind of different situation, and that may sound depressing to you, and it is a little bit, but at the same time, it's a great field to be in because you're in the position to do two things. You're in the position to try and find solutions. You're still in this is still the frontier of psychiatry. It really is. And the second thing is you're able to do everything you possibly can to try and decrease those symptoms in terms of severity or frequency of onset. So it's an interesting field because you're able to explore and do different things. Aaron Beck died earlier this week. Anyone know who Aaron Beck is? Aaron Beck is a guy who went to medical school in the late 50s, early 60s, and learned at University of Pennsylvania in their psychoanalytic school how to do psychodynamic psychotherapy, which was the therapy back in the 50s and 60s. There was no other therapy. It was based on the theories of, and I emphasize the word theory, the theories of Freud. And there was a lot of what we call free association. So literally there were couches in the offices, and the couches were used by the patients. And the patient would lay in the couch and face in the opposite direction of the psychiatrist. The psychiatrist and the patient would not see eye to eye, literally, not figuratively. And the patient would free associate and go through periods of catharsis and basically just talk. And that was psychodynamic psychotherapy or psychoanalytic psychotherapy. And Aaron Beck did that for a couple of years and just saw a couple things. He saw a pattern in patients, a pattern where they would have these thoughts that didn't make any sense. They weren't based in reality. No, they weren't delusional or psychotic, but they were thoughts like, I'm no good, no one likes me, everyone hates me, I'll never amount to anything. These really destructive but inaccurate thoughts. And those inaccurate thoughts were tied with depression and anxiety. Now we know they're tied with other things. But at the time, they were tied with depression and anxiety. He saw a link between those destructive, inaccurate, wacky thoughts that were persistent. And he saw the link between those thoughts and emotions or feelings like depression. And he made that connection and he developed a way to address it. And he called it what? Anyone know?
Cognitive behavioral.
Say it again.
Cognitive behavioral therapy.
I call it cognitive behavioral therapy, CBT. So psychiatry was in the frontier then when Aaron Beck did this, and it's still in the frontier. Now, luckily, we have CBT. He died at age 100, but during his 100 years on this planet, he did a lot of good. And he came up with something that was very innovative and very evidence-based, and it really works. Cognitive behavioral therapy is a mode of therapy that we use to help patients who are struggling. And so for me, as a medical student and early in residency, I learned about cognitive behavioral therapy. And I really, and it really became clear to me that there are many ways to learn or to explore different modes of therapy that can help people. And so the downside is we really don't know what the heck we're doing in psychiatry. It's true. We just don't. But the good news is that gives us the opportunity to innovate and be creative and come up with solutions and to explore even further. I think we don't know the pathophysiology in psychiatry because I think it's multifactorial. And when something is multifactorial, it's hard to say, this part of the brain is affected or this gene causes schizophrenia. And so it's still an enigma to us. It really is. Questions on that? I know it's kind of philosophical, but it's important to understand. So let's jump into, some less philosophical topics here and talk about the fact that many of you are interested in psychiatry, right? But the fact of the matter is that most patients who get psychiatric care are not getting it from psychiatrists. That's kind of weird, isn't it? They're not getting it from psychiatrists or psychologists or social workers, but instead primary care providers. They're delivering the large majority of this care. On any given day in the world of primary care, about 40%, sometimes up to 50% of patients seen have significant psychiatric issues, 40 to 50% on any given day. Now, the PCP may say, well, I'm going to refer you to psychiatry. Well, that's fine, but 50 to 60% of referrals don't really take place for many different reasons, and I've listed some here. So here you're in a situation where you're PCP, you see most of the psychiatric issues, patients who have psychiatric conditions. You try and refer, but 50, 60% of the time it doesn't work. And to add on to that mix, and this is the truth, this is the reality, primary care providers were not trained, are currently not receiving sufficient training to deal with this in their clinic. They're just not. I'll give you some examples. So physician assistants are primary care providers. They spend about 40% of their day seeing patients who have psychiatric conditions. Anyone want to guess? In the state of California, which has more rigorous requirements. Does anyone want to guess how much time physician assistant students must spend learning psychiatry before they're eligible to become PAs in the state of California? Anyone know or want to guess? How many months?
I'll guess 1 month.
Okay. Other thoughts? It's kind of low though, but any other thoughts? I mean, you can't learn psychiatry in a month. As a medical student, sure, you'll probably get 4 to 6 weeks. So here's the answer. It's 2 weeks. PAs get 2 weeks. Internal medicine docs, right? 3-year residency, 3 years of residency where you have to learn all the cardiology, hepatology, oncology, all the ologies, and you know, work about 80 hours a week, and you're learning all this stuff. The American Board of Internal Medicine requires how much time to learn psychiatry during those 3 years? 3 years of training. Anyone want to take a stab at this?
1 week.
Okay.
1 month.
Okay. That's closer to probably what might be reasonable. Any other thoughts? Well, I'll tell you the answer. It's 0 seconds. 0. 3 years. 0 seconds. 0 minutes. No weeks. 0. There's no requirement. Now, internal medicine docs, you know, some of them will go into primary care and they'll practice primary care, but how can they deliver this care? How can they deliver 75% of the care in this country when they don't have the training? When they try and refer, but 50 to 60% of the time it doesn't work, right? How does that happen? It doesn't happen very well. In the primary care setting, about over half of depression is not accurately diagnosed and not effectively treated. And we see that antidepressants are written largely by non-psychiatrists, right? And who knows what they're writing for because they didn't get this training. And more than half of primary care patients on antidepressants don't even meet the criteria for depression. There was a study done in 2002, a long time ago, but I think it still holds true now. A third of internal medicine residents surveyed were comfortable treating depression, right? Only a third. And that's just depression. If you add on a little substance abuse, a little personality disorder, a little anxiety, shake it up, it's going to be, the number's going to be a lot lower. Now, this is a problem. This is a problem because you can see at the top of the screen, right? Depression is the #1 cause of disability in this country. Suicide rates have decreased over 30% in the last 10 to 20 years per CDC. So there's an urgency here. There's an urgency to increase workforce, which is great to see all of you on the call this Saturday morning. But there is an urgency here, right? And so, and it's really not being met, you know, frankly. So that's a huge problem. Again, just showing here that, you know, about 60% of folks who are struggling with significant psychiatric illness are not getting treatment. Those 40% who are getting treatment, most are being seen by general medical docs or non-psychiatrists, non-behavioral health folks, right? Now, there is some good news here that if you compare, you know, going back to 2014 or 15, the number of people or medical students applying for psychiatry has increased significantly, which is good. But it's not even coming close, as we'll see in a second, to meeting the need that we have in our country or in our regions, since in California. By the way, I don't know if you guys know this, so I'll just share it with you. It's more difficult to get into psychiatry these days. Right now, I think I'm working with, I don't know, 4 or 5 medical students who are really struggling to get interviews. And again, I'm sharing this with you just so you know. And I think there's a couple of reasons for this. One is because there's more interest in psychiatry, but that's not the main reason. I think the main reason is we have this Zoom interviews. And so a lot of people are applying to a lot of programs and it's flooding the system. It used to be that you'd only apply to maybe 20 programs because you have to pay for airfare and all this other stuff. Now you just have to get on Zoom. So, you know, people are applying to 90, 110 programs. I mean, it's very different. we're also seeing some folks nervous and applying for 2 or 3 different areas in medicine. So they might say, well, I really want to get an optho, but if I don't, my backup psychiatry. So we're seeing some of that as well. But it is challenging. It is, I would say, more challenging than I've ever seen it in my career as being a program director. Very challenging. And again, I don't say that to discourage you, but I say that to inform you. Again, the numbers are going up, but I think this whole COVID thing is making things a little bit more difficult. When when you're able to do a Zoom interview, it's much more easy to do that, and the number of interviews per applicant go up, or the requests for interviews go up. Any questions on that?
So Dr. McCarron, my
I-
question.
Yeah. Go ahead.
Oh, sorry. My question for you is, do you think we'll ever go back from Zoom to in-person interviews ever again?
I think we'll go back to in person. Yeah, I think we will. Yeah, I
Okay.
do. Yeah.
Is that going to happen anytime soon within like any of our medical education careers?
Well, my hope is it'll be next year. I mean, I think it'll gradually come back. So I see next year or the year after, but hopefully next year as a transition where you can choose to do Zoom or not. And this year it was really almost mandated, across the board through ACGME. So I see it as a transition. I think that some programs will continue to have Zoom and or in person. So we call a hybrid approach. For those of you who are on the interview trail now, are you hearing some of this? That it's a little more challenging these days relative to a couple years ago? Anyone hearing this?
Yeah, I definitely am. I know programs are paying a lot more attention to regional ties that you might have.
Yeah.
So any indication that you actually want to live in the area, it's, for me, just reaching out to programs personally and expressing interest outside of just an application has also been helpful. But yeah, I think the dynamic has definitely changed.
Oh yeah, no question. Yeah, so it's yeah, but I don't say that to discourage you, but and hopefully things will change back by next year. So all right, so this is basically just looking at the health professional shortage areas for mental health, and the blue part's bad and most of it's blue. We see little pockets here of by the way, the gray areas are just non-shortage areas, right? And there's not a lot of gray. You can see here, it's a little bit here, a little bit on the northeast, a little bit here, on the eastern part of California. But really, most of this is blue, and which indicates a higher level of shortage that we're facing. There's older data, but still holds true with from the AMA, which shows that psychiatrists, we're running out of psychiatrists. So about 70% of psychiatrists are over the age of 50 and really looking for, to retire. This is data from 2020 from a UCSF study looking at number of first-year psychiatry residents and child and adolescent psychiatry residents per region in California. And there were a total of 1,858 general psychiatry positions nationwide. So we see here, if we look in the area where, if we look at California in general, we see there's a total of 186 spots, and then for child it's 54. Central Coast, there's 0. If we look at Inland Empire, which is huge, collectively there's about 30, only 53 in the largest county in the country. Orange County is the 6th largest county in the country, only 9 spots there and 4 for child. So even if we tripled or quadrupled these numbers magically, which won't happen in my career, for various reasons, usually because of funding from the federal government for these spots, we won't come close. We're not going to come close to meeting the need. And so if you look here, it's the projected supply and demand for psychiatrists, looking at 2016, projecting to 2028. We can see that the supply here is not meeting, the demand. And even if you look at the projection, we see here that you know, if we look at 2028, the unmet need is 7,700, and we're looking at a supply of about 3,800. Now, this is problematic for many reasons. Number one is it's not good for patient care. Number two, it's not good for our profession, because when this kind of thing happens, like it is right now, we see a lot of non-psychiatrists wanting to jump in the mix and do the work of a psychiatrist. Put another way, they want to do the work of a psychiatrist without doing the training that all of you are planning to do. So example would be psychologists really wanting to, quote, prescribe. Well, prescribing is the same as practicing medicine. When you're prescribing, you're practicing medicine. And so there's a big push nationwide for psychologists to prescribe. And that's not a good thing. Nurse practitioners now have the ability to practice without the supervision that they used to have by physicians, which basically means, and we see this in the state of Oregon and several other states, is that nurse practitioners can basically practice on their own. So they could see psychiatric patients on their own. And again, without that extra robust training. And that translates into suboptimal patient care. So that's one of the issues I want you guys to be familiar with. I want you to know where we're at, where we're going, you know, and the need for psychiatrists. So we'll talk about access. I mean, really the bottom line is, we'll see a little bit more, but I'll show you some data on this, but a lot of our patients who have psychiatric illness are receiving suboptimal health care, meaning suboptimal mental health care, but also suboptimal preventive and primary care. And when they have that suboptimal care, really we see that there's a need, you know, there's a higher a number of those folks coming into our ERs, and then this population really becomes underserved and vulnerable, uniquely vulnerable, because they're not getting this care. And if they do see primary care, God bless primary care. I'm a primary care doc too. So, but they just that experience and the knowledge base and how to treat is just not there. Now, sometimes it's important to look at workforce expansion as increasing opportunities for education. And so I'm going to give you an example of one thing that we've done at UCI, which I think is kind of interesting. I also show this to you because if you do get into psychiatry, there's a lot of cool things you can do, right? As opposed to the standard stuff that you might see. Sitting in a chair, for example, all day long, seeing patients, or being in the emergency room all day long. There's a lot of different things you can do, a lot of ways to be creative and innovative. So at UC Irvine, we created the Train New Trainers Primary Care Psychiatry Fellowship Program, where we squarely address the deficits in the number of psychiatrists or the number of providers who can deliver care, psychiatric care, mild or with mild or moderate severity. We directly address this by realizing PCPs are already delivering this care in large margin, but they don't know how to do it. So what we decided to do is recognize the fact that they're already providing the care. It's already happening, but we're giving them a booster. We're helping them to be better at this, which we think not only expands care, but optimizes care as well. So we provide we teach them how to provide a targeted psychiatric exam, focus on common psychiatric disorders, when to refer. We also, the Train New Trainers component helps them learn how to train other providers. So they're learning this information and then they're passing it on. As a one-year program with longitudinal training, during each month they get 2 case-based teleeducation learning modules. They also have 1 hour or 2 hours of mentorship with a faculty who's dually board eligible and certified or trained in either family medicine psychiatry or internal medicine psychiatry. And then we have 2 intensive weekends. So we had the pandemic hit us a little bit hard here, but we got up to 234. We'll probably have about 350 fellows in January. Just received a $10 million grant to train over the next 4 to 5 years as many PCPs as we can in the state of California. And again, the idea is strategic. Who's already delivering this care? And let's help them deliver it better. So we're not training them to be psychiatrists. There's no way we can do that, but we are training them to have early recognition and more effective treatment for mild and moderate conditions that are commonly seen in the primary care setting. These are some topics that we cover. Again, how to do an exam, mental status exam, cultural psychiatry, mood, anxiety, trauma, substance misuse, psychosis, cognitive behavioral therapy, motivational interviewing is a big one, collaborative care, etc. This is our faculty here. We have about, I think now 37 faculty nationwide who help provide this training. And so this is, again, an innovative, out-of-the-box, creative way to try and address this problem. Again, I don't see this country increasing the number of psychiatry spots by 4-fold or even 2-fold in the next 20 years. Again, the federal government would have to pay for that. And they're using the same numbers from the mid-1990s in terms of paying for GME spots. Questions on any of that before we move forward?
I'm curious about the PCP program. Is it mostly extended to training family medicine and internal med doctors, or does it extend to like OBGYNs and peds doctors too?
Yeah, no, it extends to all PCPs. So that would include pediatrics, OB-GYN, NPs, PAs, internists. We even train ER docs. So yeah, it's more sort of broad-based. Yeah.
So Dr. McCarron, I think these programs are awesome, but I feel like an issue with family practice, I haven't had experience with that, but in internal medicine and like my previous rotations, maybe even surgery, I notice it's like an education of trying to convince providers that psychiatry matters, or psychiatry should be an option for those patients. So I guess my question is like, how do you, it's not so much like creating a program for people to learn how to treat psychiatric conditions, but how to broadly make providers care.
Yeah, what I've learned over the years is most providers care, but they don't know what the heck they're doing. I mean, imagine this. Imagine you're a primary care doc, right? And you start on a Monday, your first day, and then you're 3 months into it, and 40% of your day is seeing psychiatric patients, but no one trains you on how to do it. That would kind of suck. That job would be horrible. The burnout rates would be high. And what we do is we measure self-efficacy rating scales, burnout rating scales, pre and post in our learners. And we find that when they go through this program, they feel much more at ease and comfortable dealing with this 40% time, which makes them like their job more. I think providers might say, oh, that goes to psychiatry. And I think they say that in kind of a grumpy, almost angry kind of way sometimes because they don't know how to deal with it. And they also say it in a grumpy kind of way because they know what I just told you. If they send a referral, those referrals aren't going to happen. And what's going to continue to happen, that patient's going to continue to see the primary care provider. And the primary care provider is going to continue to say, I don't know what to do. And many primary care providers say, I only prescribe lisinopril. I don't prescribe Prozac. Again, early in my career, I was like, well, what's wrong with you people? Why don't you deal with this? This is your job, right? But then it became very clear to me, and it changed the trajectory of my own career in terms of what I do. They don't know what to do. They don't know. No one's told them. No one's taught them. So that's what we're doing at UCI is we're really taking the time to train them as best we can. Does that make sense?
Yeah, thank you.
But as a medical student, I could see you rotating with some of these folks, and you could probably just feel like they're uneasy and anxious themselves when there's a patient coming in with depression or anxiety, et cetera. And I'm sure you can see that. Well, again, if they learn how to do it, it'll be better for them. It's almost like they know how to treat dyslipidemia, so it's easy for them. They're not feeling anxious about it. It's like, okay, here's your LDL, here's your total cholesterol, we're going to give you this statin. Follow up in 3 months, right? So why psychiatry? So suicide is the 10th leading cause of death in the United States. This is for adults. On average, about 130 Americans die by suicide each day. 1.4 million Americans attempted suicide per year. Most of them had a diagnosable mental illness. 10%, I'm sorry, 50% of those who killed themselves have seen their primary care provider within 1 month before suiciding. About 48,000, now it's closer to 53,000, die by way of suicide each year in this country. It's the second leading cause of death for those between ages 10 to 34. The fourth leading cause, 35 to 54. Firearms are the main culprit, and so it's a big problem, right? And if you look at kids, this was a study that just came out of UCLA. 45% of California youth between age 12 and 17 report a mental health condition. 45%. A third of them experience serious psychological stresses. A third. Huge numbers. These numbers were measured pre-COVID. Suicide, second leading cause of death among adolescents. The number of female adolescents suspected of a suicide attempt during an emergency room visit increased by about 50% since the start of the pandemic. So that's a measure. That's a measure that we know, from the pandemic time period. We were recently asked by the Orange County Department of Education, K through 12, to help address this. They're struggling. The teachers are struggling because they have to deal with this. We came up with a proposal called I-TEACH. I won't go into it, but it stands for Integrative Transformation, Education, Administration, and Children's Health, which really is a program designed for senior level people in the Department of Education in Orange County, superintendents, principals, assistant principals, to learn how to detect, prevent, address common mental health illness in students. And they're going to learn how to do that. And they're also going to learn how to be healthy, how to use whole person care. And then we also slip in some helpful hints on leadership and how to use motivational interviewing techniques and cognitive behavioral approaches to help with leadership as well. And the plan is to teach them, so that's disseminated to the teachers. They're able to teach their own teachers, and hopefully that'll filter through. But right now, this is a big number, 45%. So we're going to move on just a little bit to our question for you guys. Should psychiatrists help their patients to reduce risk of vascular disease? A, no, not necessary, because this kind of thing is done in the primary care setting. B, no, this is clearly outside the scope of practice for the field of psychiatry. C, yes, there's an unfilled need for this, and increased morbidity from vascular disease disproportionately affects our patients. And D, not quite sure. Jury's still out on this one. So why don't you guys just, if you can, just chat your answer. Okay, so C and D mainly, yeah. And so let's talk about this and look at some information, and so we can get a better idea. This is a book that my colleagues and I put together, that it helps psychiatrists and psychiatry residents learn about preventive medical care in psychiatry. So preventive medical care for those who have psychiatric illness, covering cardiovascular, pulmonary, endocrine disorders, metabolic, infectious disorders, oncology, and special topics, including pain, geriatric, and child psychiatry. We put this book together with the American Psychiatric Association because there was a need, right? There still is a need, and I'll point this out in detailed form here in a second. But the need is patients who have particularly severe mental illness they're not getting this care. They're just not. So if we're training psychiatrists on how to do some of it, that's going to help them, and that's kind of the goal. So patients with chronic mental illness have significantly higher rates of medical comorbidities, lower life expectancies when compared to the general non-psychiatrically ill population. People with schizophrenia and schizoaffective disorder die about 20 or 30 years earlier relative to the patient population, a couple decades. Same thing with bipolar disorder. Patients with bipolar disorder also have a twofold higher mortality rate when compared to those who don't have mental illness. And then depression, people who have depression are much higher risk of developing general medical conditions like diabetes, hypertension, ischemic heart disease. So this is a huge problem, right? And you know, I put up this road sign here, caution, water on road during rain. It's kind of a silly road sign, right? But the reason I put it up is because many of us know this already. Many of us know that people who have severe mental illness are particularly vulnerable. We know this, but there's not a lot that we're doing about it. This was a sentinel study that came out in the spring of 2006, looking at increased mortality rates and years of potential lost life in those from 8 states, looking at public health from a public health standpoint. So let me just go through some of this. We're looking at years of potential lost life over here, or YPLL, in patients who are in a public mental health setting or have Medicare or Medicaid. We call Medi-Cal in California. And so if we look at Missouri, the years of potential lost life is about 30. Oklahoma, about 30. Rhode Island, about 25. Texas, about 30. 30 years of potential lost life. Utah, 26. Virginia, 16. And Ohio, 32. That's not good. And this is one of the reasons I got into psychiatry is our patients are dying too soon. And before they're dying, they're suffering. So they're suffering and then dying too soon. Patients in the world of psychiatry are uniquely vulnerable. And what's fun though is that as a psychiatrist, there's stuff you can do about it. Some more information I want to show you. So if we look at patient-specific health factors in those who have schizophrenia, this is the prevalence for the general patient population. This is the prevalence for schizophrenia. So those who smoke, much more likely to be schizophrenia. This is anywhere from, it depends on the region, it can be as low as 10 to 20%. Obesity is much higher in those who have schizophrenia, diabetes much higher, HIV much higher, and even hepatitis C much higher than the general patient population. This is looking at rates of medical comorbid conditions in those who have schizophrenia, and looking at their odds ratio. So an odds ratio of 1 is normal. Just so you know, an odds ratio of 9 is huge. When we look at emphysema or chronic bronchitis, they're more likely to have liver problems, asthma problems, or reactive airway disease, and renal problems, diabetes. The list goes on. So this is not just a mental illness situation. This is also what I call a general medical problem. You know, so automatically when I'm treating someone who has schizophrenia or schizoaffective disorder, bipolar disorder, severe refractory depression, I'm automatically thinking about their whole person and automatically thinking about their increased risk for getting cancer, hepatitis C, HIV, etc. Again, more data looking at standardized mortality ratios in those with schizophrenia and bipolar disorder. Again, a 1 indicates a normal mortality ratio. If we look here, I want to point out infectious diseases for schizophrenia, it's 4.6, and then for bipolar, it's 7 to 14.8, which is extraordinarily high when the normal standardized mortality ratio is a 1. And that includes a lot of different types of infectious disease. Hepatitis C in particular is quite high in those who have schizophrenia. Let's skip over this one and go to this. So this is data from the Katie trial, which was a study published in the New England Journal of Medicine, which looked at 13,000+ people with schizophrenia and schizoaffective disorder from multiple different sites. And we'll walk through right over here where we see diabetes. So 11% of those people had diabetes, right? 11%. And a third of them were not treated for that diabetes. A third just were walking around with it, right? 33% of people had hypertension in this study, 33%. And 2/3 of them were not being treated. They weren't diagnosed, they weren't treated, they were just walking around with hypertension. when we come to dyslipidemia, about 70% of them had dyslipidemia, right? And almost 90% of them weren't being treated for it. So they have these conditions. Many of them don't know they have the condition. They're not diagnosed and therefore not treated. Again, uniquely vulnerable. So an example of what we can do as psychiatrists is address the number one cause of death, you know, per the CDC, and that's diseases of the heart, right? Cardiovascular disease. Are any of you familiar with the ASCVD? Does anyone use this? Yeah. So this is a very easy to use. You can take out your iPhone or whatever and use the app, and you just click on their gender, their age, their race, total cholesterol, HDL, blood pressure, diabetes, and yes or no, are they a smoker? Press calculate, and it will tell you their risk, quantify their 10-year risk for badness, cardiovascular badness, or cerebral vascular badness, or a bad vascular event. And so it's easy to do. Psychiatrists can do this and quantify this estimate in their chart and address it and talk to the patient about it, particularly if they're not seeing a primary care provider. Now, I want to take the next 20 minutes and go over lipid metabolism, and we're going to talk. I'm just kidding. I'm joking. I saw the look on your face, all of your faces. I bring this up here just to show that a lot of the general medical conditions are complex. There's a high level of complexity, and psychiatrists, you may not know it or remember it or want to know it, but at the same time, there's certain simple things that we can do, like check lipids and determine whether or not there's a lipid abnormality. Even that alone can be very helpful. So I talked earlier about the fact that we really don't know what we're doing in psychiatry. I know that sounds horrible, but it's true from a pathophysiology standpoint. Instead of this doctor saying, here's your MRI showing where you have depression or schizophrenia or PTSD, he's sort of putting up the picture of this woman who looks depressed and saying, it looks like you have depression. We don't know. We don't have a lab test that's going to say, hey, this is what you have definitively. So how do you do psychiatry? Moving on to how you do psychiatry, and I'll finish in a few minutes. I think one of the most important things we can do in medicine, and I teach this to medical students, is whatever you do in medicine, do it empathically, right? So become the patient, understand where the patient is, understand that they are uniquely vulnerable, how they're uniquely vulnerable, and connect with them as much as you can in that way. Partnerships can help with delivery of care. So we talked about integrated care, consultation, collaborative care. Someone mentioned interest in combined training. Family medicine psychiatry, internal medicine psychiatry builds bridges together. It helps, I think, deliver better care for patients, and then telepsychiatry, both synchronous and down the road, hopefully asynchronous. I want to thank all of you for listening. I know I've been going on and on here, and I know we covered a lot. You know, some philosophical, some more specific. I also realized that some of the stuff I covered might be a little discouraging. Specifically the fact that we don't know the pathophysiology in psychiatry, and also mentioning the fact that we don't have enough psychiatrists, and that it's more difficult to become a psychiatrist, I think, these days, and reasons why. We also talked about COVID and how COVID's still creating a mess for patient care and delivery. But I want to end by saying getting into psychiatry is pretty cool, and this is why. Because you have a lot of opportunity to do really innovative and creative stuff if you want to. You have the opportunity to be an Aaron Beck. You can create your own type of psychotherapy that you think might work. I've spent hours and hours thinking about what might help patients more who have somatic symptom disorder or depression or anxiety, and in my own practice, I use sort of an eclectic approach where I take different pieces of psychotherapy that I like and that I think are important, and I use it to help the patient. So there's a lot we can do. There's a lot of good that we can do, and I think the future of psychiatry is bright. So I'll end there, and I want to thank all of you for listening, and I'm happy to take any questions that you might have. I'm also mindful you have a busy morning, so you have probably a lot going on and coming up here. So if you have any questions, there's my email address, and feel free to, send me an email if you have any questions. It was a real pleasure. Danby, thanks for inviting me to speak. And again, happy to address any questions that you guys have down the road. And I'll finish with that, okay?
Yeah, thank you so much, Dr. McCarron, for coming and speaking to us. I feel like the things that you mentioned were very insightful and in some ways very thought-provoking too. So I guess I'll just leave some time for all of us to process, to take a break, but we're really grateful to have you.
Well, thanks very
really
much.
Wonderful.
Enjoy your weekend. Bye-bye.
Thank you. Goodbye.
You're muted.
Shoot, so this whole time, okay, he didn't hear me. Okay, so thank you everybody for just being here. We're gonna give a talk around 10:30, so I'll just give you all a break for now, and then we'll reconvene in about 10 minutes, okay?
Danby, do you want to put the main page back up?
Yes, I will go put that back up.
Yeah, I got it. Give me 1 second.
Actually, thanks,
Hi, Dr. Moffic.
Hi.
Hello, good to see you.
Yeah, a person, a virtual person.
So we're on a quick break right now.
Okay.
About 2 more minutes, and then Jennifer and I will introduce you, and then you can be here.
Okay, great.
Okay. Thank you so much for being here.
You're welcome. Yeah, should be interesting. How many people do you think might be there?
Dan, maybe 15 to 20.
Okay. Yeah, because besides introducing me to them, depending on the number, it'd be probably good to get a quick, a quick introduction from each of them too, maybe.
Yeah, definitely.
Yeah.
Yeah, thank you, Dr. Moffic. Yeah.
Hi.
Hi, I'm Danby. I was the one that was communicating with you.
Yeah, I see
it's
you.
good to meet you. Yeah, it's good to see you too. So yeah, we are gonna have around, we're hoping that maybe like 15 to 20, we'll have 15 to 20. I think that's what happened with our last talk. People sort of trickled in.
Yeah.
Yeah, but something I wanted to ask you, is it okay if we record this talk today?
Sure.
Okay.
Yeah, it's okay, especially if it's, okay with everybody else. Yeah.
Yeah, I know some people also have busy schedules, and some have even told me that they want to watch the recording. So
yeah,
they would have loved to be here today to listen to you, but at least they'll have a recording of you too.
Yeah, that's fine.
Thank you, Dr. Moffic. Okay, we'll begin soon. I'll leave it to Pooja and Jennifer to take it off.
Okay.
Jennifer?
Are you good to start? Okay, so hi, Dr. Moffic. Thank you so much for joining us again. My name is Jennifer, and Pooja. Nice to meet you. Me and Pooja are going to be introducing you. So just to give a little intro on Dr. Moffic, Dr. Moffic is an award-winning psychiatrist who has specialized in cultural and ethical aspects of psychiatry. His love for psychiatry was sparked by Freud, and the rest was history. He attended Yale Medical School and went on to complete his psychiatry residency at the University of Chicago. Throughout most of his career, Dr. Moffic was in academic psychiatry as a professor of psychiatry, first at Baylor College of Medicine, and then later on at Medical College of Wisconsin, where he tenured and later retired. He is passionate about the ethics of psychiatry as well as physician burnout, and has dedicated his life to addressing these important issues.
Dr. Moffic is a member of the APA's work group on burnout and wellness, and has given numerous presentations on burnout for the PsychSIGN national and regional conferences. He serves on the editorial board of the Psychiatric Times and writes a daily column on psychiatry and society, advocating for mental health issues related to climate instability, burnout, Islamophobia, and anti-Semitism. He has authored and edited several books, including The Ethical Way, Challenges and Solutions of Managed Behavioral Healthcare, and Combating Physician Burnout, a Guide for Psychiatrists. Currently, Dr. Moffic graciously works as a pro bono community psychiatrist in Milwaukee. He is the recipient of the one-time designation of Hero of the Public Psychiatry from the Assembly of the American Psychiatric Association, and a recipient of the Administrative Psychiatric Award from the APA. This award is the highest leadership and administrative honor that the APA presents. He is a strong advocate for social and mental health issues related to physician burnout. Today, we have the honor of introducing Dr. Stephen Moffic.
So all that sounds good. Now you'll kind of see the real me. Besides my being introduction, it's a little, you probably already know this, it's a little difficult to kind of go across the room online, but it would probably help me and maybe help each of you, depending on how well you know each other, just to introduce yourself really quickly, one by one. And by introduction, I mean your name, what year you're in, and very briefly a sentence of what you want to get out of today's interaction. So we can go in any kind of order that may work. So
I can start first.
Okay.
Yeah, so my name is Danzy. I'm a third-year medical student at Western University. What I hope to get out of this is that I just feel like even in med school alone, there's been a level of burnout that I faced, and I know in psychiatry as well. I know there's a significant amount of burnout among those physicians. So I just wonder what I can take from this in learning to prevent burnout amongst clinicians, and also as just a med student that I can take with me through my student career, I guess.
Okay, fine. Just right. Next.
Okay, so I'm Pooja. I'm a third-year medical student, also at Western University. I think that the medical field has kind of ignored the mental health of their own providers, and it's really hard to care for others when you can't care for yourself. And so I think it's just a system-wide change that needs to happen.
Okay, yes, you got it.
I can go next. So I'm Jennifer. I'm a second year at Western U as well. One of the main things I kind of want to take away from this talk was I know that burnout is definitely a very prevalent topic in medicine in general. And I think that with COVID, things have just exacerbated, and I want to see, if there's any ways and steps that we can work towards to kind of improve the culture and atmosphere surrounding physician and burnout. So that's one of the things I wanted to take out of it.
Yeah, good. Thank you.
I can go next. My name is Ivan. I'm a second year medical student, also at Western University of Health Sciences. I think the big thing I want to take away from this talk is that burnout and physician suicide, as well as an issue, similar issue in medical students and medical trainees, has already been a significant issue even before the pandemic, and now even more so with hospital rooms overflowing and having to adjust very quickly at the beginning of 2020 to even now to deal with the pandemic. I think my cohort is a little bit unique in that we started medical school at the start of the pandemic, and we only kind of know how to go about our medical education in the midst of the pandemic. So I think what I want to get out of this is how do we kind of learn to adjust and adapt to this, knowing that we still have to face all the normal burnout kind of obstacles that we'll have to face going forward as we continue our medical training.
Okay, thank you. Next, anybody?
My name is Isaac. I'm a fourth year medical student at Loma Linda University. I think it's already been voiced, but I'm just interested in what steps we can take to prevent burnout, especially during this pandemic time. Thinking both about healthcare professionals, but also patients.
Okay, got it. Thank you. Next.
Hello, my name
Hi.
is Eileen. I'm also a second year medical student at Western U, and I think everyone said what I wanted to say. So I'm pretty excited for the talk.
Thank you. Anybody else? Next.
I think some people might have come in late. I think I'm just going to reiterate that we're just doing introductions right now, stating where we are in a medical career and what you're looking forward to in this talk.
Right. Thank you. And it's okay if you don't want to, but if you want to introduce yourself, just speak out. Okay, maybe I'll go ahead. What I thought we'd do is actually I'm gonna try to give you. Everybody wondered how to prevent burnout and deal with it and so forth. So I may just give you the generality of what to do about that before I start getting into more depth. And I thought I might talk in maybe 15 minutes, 20 minutes. I want to read you some excerpts from an article about first-year residents at my medical school who have had to cope with this. And although they're first-year residents, to me, it's more or less like what medical students are going through. So my hunch is probably half of you are burning out. if you want to use the common statistics out of second year, third year, maybe the second half of second year, third year, and first half of fourth year medical students, that's the percentage of how many burn out. And before then and after then, it's not so prominent. And so those of you who are maybe before the third year, you've got some ability, I think more ability to ward this off. And how do you do it? Just very briefly, because we'll get into this some more. It's basically caused by the system, meaning your faculty, your administrators at your medical schools, essentially how they're treating you. Are they engaging you in dealing with the problems? Do you feel capable of doing what you're capable of doing, or are there too many obstacles? There's not a whole lot of vulnerability that each of you have as individuals. The percentage goes 80% or so is caused by the system, maybe 20% individual. And by individual, I mean, maybe you've had a history of trauma, or maybe you've had a history of difficulty dealing with authority figures. That might make you more vulnerable to burning out. But what can you do as individuals? As far as each of you yourself goes, it's really important to find ways to decompress and refresh yourself from what you're going through. That is, whenever you have time off, to be able to do some fun things that are important to you. Number two is find what we call a burnout buddy, at least one, somebody you can trust to process how you're feeling as time goes along, and give yourselves kind of unconditional support. And then as a group, if it's all at all possible without risking retribution, to form kind of groups for support and to try to deal with this system by sharing what you think is a problem, especially doing that with faculty and administrators. So that's a way of trying to get through this. Well, the same thing seems to happen during residency, I hate to say. Usually you start residency and you're not burned out, and then it develops, and then it sort of settles down. But how you choose a residency, if you can, is really important to find out whether the residency program seems to support their residents or not. And the pandemic has complicated everything, right? And we don't quite know if the pandemic has made burnout worse or not, but it probably has made it worse. And the whole uncertainty and the pressures of the system seem to do that. So let me read you a few excerpts. I don't know if you got a copy of this, but there was a wonderful 3-part story in my local paper, Milwaukee Journal Sentinel, about my medical school, the Medical College of Wisconsin. This was from about 3 weeks ago. So I'm just going to give you some quotes in this because it covers some of the things that I think are really important about burnout, both from a faculty standpoint and a resident and thereby medical student standpoint. So bear with me, I'm going to have to read these because I can't possibly memorize this. So at the beginning of the article, it talks about the head of medical school and residency education, but he's mainly talking about residents here. In responsibility for all residents, Dr. Simons faced hard decisions with potentially severe consequences. This is July 2020. Given the shortage of personal protective equipment, he was under pressure from some to conserve supplies for veteran staff and provide what he regarded as inadequate protection for the residents. He refused. Already, residents were concerned about the possibility of bringing the virus home to their families. He made sure they could stay at local hotels paid for by their hospital, a benefit that was being provided to other medical staff. Mistakes could lead to outbreaks among patients, staffs, and their families. And then there was the psychological toll the pandemic would take on their young doctors. These are changes that no one had faced in 100 years since the last pandemic. These are some reflections of first-year residents during that first month of 2020, July. And this is from Kim. Do ever the most confident attending physicians have moments of distress during this time? Is there, in this moment, an opportunity for all of us to track ambivalence and our hidden feelings of anxiety? And they go on to talk about the imposter syndrome that many are feeling, both medical students and presumably faculty even. This is from Mike Myers, a psychiatrist who had a support group of medical students that he was running during this time. Quote, "We don't have a treatment algorithm. We just don't know what we're doing, and anything we're doing isn't working." Jamie, another medical student, quote, "You have to learn to overemphasize the use of your eyebrows or your voice intonation to convey information." End of quote. That has to do with your personal interaction with patients, right? Months later now, they're coping differently, these three medical students that are featured. So one of them is named Jamie, and he's talking about his wife, Sarah. Quote, "I can't put into words how important that was. I can't imagine going through it without her, without being able to confide and share the emotional isolation of the pandemic." End of quote. Mark, journaling. "I was trying to make a cohesive narrative of everything that happened this year," end of quote, by journaling. Kim, quotes, "Running is a time when I forget the hospital ever exists." So like I mentioned before, they were trying to find their individual ways of coping with what was going on. Now, what did the medical school do? The college recognized that 2020 was anything but a normal year and set up virtual support groups to allow the residents and medical students to share their experiences. They were also offered free therapy sessions. One resident, after getting COVID, saw a therapist. Another processed her dreams about death and competence in the support group. And we'll jump to July of this year, 2021. And Jamie says, as a conclusion to this article, quote, "At least early in July, we had the sense that we really did cross the hump in terms of COVID and got through it. Who knows with this Delta variant, but that was the initial thought." So there's some optimism now at my medical school and some hope for the future. So I want to give you a little history of burnout going into the pandemic time, just to get a sense of what's caused it essentially. And back in my time, during my medical student time, and which I finished in 1971, and up until the new millennium, there was virtually no burnout known in medicine, in healthcare workers. It was known in other industry. It started to become a term that was used in the 1970s, and maybe 10, 20% of various workplaces, especially factories, and factories where you didn't necessarily keep your job for life, people experience burnout. But it started in medicine late in the last century. And why? The reason why is for-profit business entered medicine and eventually has taken it over to a large extent. And it used to be called managed care. That term's not used so much anymore, but it's really the same thing. And when for-profit businesses are involved, the goal can be making money over healthcare and the well-being of physicians, staff, and patients. And so in the year 2000, people started to recognize that physicians were burning out. That expanded to residents and medical students, and it reached epidemic proportions, meaning over 50% or so by a decade ago, higher than any other profession, higher than the public. And it's kind of remained at that level up until the pandemic. So 50% plus or minus. And this isn't an all or none phenomena. You could be burning out a little bit or a lot. And you may have heard of the key characteristics, and there's a scale that measures this. And our number one, emotional exhaustion. Number two, cynicism. Number three, a sense of ineffectiveness. And actually there's some reality to that sense, because in essence, you don't function as well as you usually do. And so patient care can suffer also. So it's not all or none, but some degree of burning out hovers at around 50%. Now, over the pandemic time, burnout has actually spread more to the public and other professions. It's high in nursing, it's high in police, it's high in lawyers, high meaning like 25% or so. And it's even high in parents now because of the pressures they're under. So this is a phenomenon that goes across all society, but paradoxically or ironically, it's worse in physicians. And the pandemic, in a way, offered an opportunity to reduce burnout. I mean, there was this terrible opportunity to help in this very frightening situation, life and death situation. And I think most physicians, most medical students, most residents would have been more or less satisfied if they had the ability to help as much as possible and they felt safe. But that didn't happen on and off. And now we've gotten to the stage where early on we were viewed as heroes, but now patients and families will criticize us because of policies about masking and vaccination. And vaccination can become even controversial within physicians. Not all physicians get vaccinated unless they have to by the workplace. So just wanted to put that in historical context for you all to see where we are now. It's still a major, major problem, obviously. So let me stop there, see if you have reactions and questions and whatever you might want to focus on in more depth now. Because just talking to you isn't probably the best thing to do online. Better to try to have some interaction. So any reactions, thoughts, comments, questions? And you can, recognize yourself one way or another, and you can put something in chat. I'll pick that up too, but you can also unmute yourself and just talk. Anybody? And anything else you want me to go into more depth if you don't have questions?
So I'm an MS4 right now.
Yeah.
And on rotations, I've seen that the residents are just so burned out. They're still struggling with this, because many of them haven't been able to travel to see their families because of COVID, or they've been overworked, or they haven't had the proper rotations. They feel like they're starting at a deficit. Is there any way that medical students can be helpful to the residents who are struggling, or anything we can do, to make your jobs better?
To make the residents' job better. Is that what you're saying?
Yeah, or to make them not so burned out or not so overwhelmed.
Yeah, both in reacting to each other as medical students, to residents, even to faculty, it's kind of, this is a situation where it kind of drains you emotionally. So to convey that you're concerned about somebody else, like how are you doing every now and then, is important. Compassion for your classmates or for residents or for faculties. It's like trying to give a collective support when it probably the best kind of metaphor, even though you all haven't obviously been in a situation where soldiers end up having to be their best buddies and support each other no matter what the circumstance is. I wouldn't say your lives depend upon it, except I would to some extent. Somebody brought up suicide before, and that should be on the back of everybody's mind, that can you get demoralized enough, distressed enough that you become suicidal? So if you're sensing that in anybody else, it's worth asking. Sort of being quiet doesn't help anything. But it's really concern for one another. And really that's, if you ever look at the AMA medical ethics standards, that's right up there. Patients come first, but what comes second is our colleagues and ourselves, meaning our own well-being and that of colleagues. So it should be something we're always concerned about. And you can convey that stuff in different ways, but you can convey concern for another person in a hallway conversation, but also take some time to chat about things. It's also good to share about how you're doing yourself, with other people, and especially if you're not feeling well, to not keep it to yourself. But everybody in the system is in this together, but you can't control everything that's going on. So you have to find the best way to, in essence, be resilient. You all probably heard about PTSD and trauma and so forth. And as bad as it is to experience trauma, you can come out of it stronger. And the term used for that is resilience. And how do you get more resilience? You get it by learning from the situation, having a better vision for the future, and especially what you brought up, having support from those around you, whether that is at home, in friendships, or others in the workplace. So you want to come out of this more resilient, and hopefully you want the rest of your colleagues to come out that way. That's the only way to get through this time without too much emotional scarring that's going to affect you in the future. So I don't know if that answered your question, but but you're bringing up a really important challenge, to kind of help one another.
No, that was definitely good in terms of answering things to be alert to. Just if there's anything else that we can do. I know the residents right now are pressed for time and completely overwhelmed. If there's anything practical that as an MS4 would be helpful or would make things easier for them so they don't get so burned out, besides just asking them once they're already burned out or once they're already struggling. That was a great answer, and it was really good things to think about. But God willing, I would be hopefully able to do something to help before I'm at the point of asking about suicide.
Yeah, and anybody else who's had a experience with what your question is leading to, please speak up. I think, like you said, with little time, it's best to kind of convey your concern on the fly, meaning, do you need any help with such and such? If it's a situation you think you could help with, how are you doing? If you've seen the resident go through a difficult time, taking 5 or 10 minutes to go chat and process what's going on. It isn't the quantity of time that's available, it's the quality of time that you're with somebody that makes all the difference. And so any way you can show concern and ask if you can help, I think goes a long way. It's people in this situation can really feel alone. And the challenge, one of the challenges of burnout is you can still feel satisfied in the sense that you're still doing the work that you wanted to be a physician to do in the first place, and you could not even realize you're burning out at the time. It's not because you're trying to repress that or anything of that psychological nature. You keep trying to do what you're supposed to do, and you could feel satisfied, but underneath it, you can feel the sense that you're losing your emotional strength. And that can be picked up by other people, sometimes better than the person themselves. So if you see someone who's even more tired or emotionally they seem different, that's a clue they're burning out. I'm going through those 3 items again. If you pick up that a resident has become more sort of a cynic about things, that's another tip off, and you maybe want to talk about, hey, you seem to be a little bit more cynicism about what's going on now. Is something going on that's bothering you? And the last is a sense of less effectiveness. So if you're picking up from a resident that they're not doing as good a job, then reality shows, again, that's another hint, and to try to have a conversation about that. You know, the plus about being a medical student in terms of a resident is, you know, you're not a threat to them if they tell you they're not doing so well, because usually there's reticence to talk about not doing well, sometimes to peers, but to people above you, because then you think you're going to be viewed as not strong enough to be a physician or not capable enough. So, so you're safe as a medical student for residents to talk, because you're not really a threat to their future by any means. So for you to be thinking about that, I think is wonderful and potentially helpful. I think as long as you have that attitude, I think you're inevitably going to be helpful. So.
Great, thank you so much. That was very helpful.
Anybody else had experience with that sort of issue? Let's see, and I see a couple of comments by Caitlin. So she's a third-year medical student. The current residents are 1% the greatest of all time. That's wonderful and unusual. Okay, and then on my third-year psych rotation, I had an attending who admitted to us when he was struggling, set a super, super positive culture where everyone else was open to do so. Yeah, you know, to break the ice, to show that you're kind of not even suffering's not the right word, but that this is such a difficult time is so important. And the higher up you are that do that, like an attending, the more helpful it is. But it's important to find a place for everybody to do that. Again, whether it's in your home life or with what I said was a burnout buddy or anybody, I'd be surprised. Well, first of all, taking away burnout, taking away the pandemic, being a medical student is never easy. And so way before these last couple of years, medical students suffered, and so did faculty, and so did residents. But, you know, we try to put on this front of being super strong. And in some ways, that's good. You know, we're faced with life and death challenges. We have to work so hard and so long that we have to build up what we think is a tough exterior and just bite the bullet and be strong. But I think over time we've shown that has deficits. So we also have to find ways to safely share that we're struggling and not have that viewed as a weakness. So to have an attending do that, and I'm pleased to hear that it was a psychiatric attending who did that, is really a wonderful role model. So that's quite nice to hear. And that's where, you know, faculty can be helpful if they admit they're struggling, and it's kind of a collective goal to be able to cope with this as well as possible. So thank you, Caitlin. Other issues, ideas, anything you want me to go into more depth?
So Dr. Moffic, just going off that, I have a question about, you know, it seems like a lot of the factors that we face are external factors that can drive burnout.
Yeah.
And I really appreciate Brianna and Caitlin's input. I just wonder, like, what it is also that not only we can do to help residents, but also what we can do to advocate and like help ourselves when we experience those things. And I feel like as med students, you kind of are at the bottom. You just kind of have to just take things as well. That's kind of the mentality that I've set for myself. So I just wonder what you advise is the balance between knowing that this is the path you take as a medical student to go through these challenges versus what can you do to advocate for yourself and protect your own self as a medical student?
Yeah, for yourself, first of all, in a way, what we're doing here today, you recognize this is a potential problem or already is a problem that is affecting you. So, recognition is the first thing. And then whatever you can do to, again, kind of recoup from the pressure you're under. And, some of the examples in the article I gave you, you have to find your own. You have to find your own way to decompress and use the time to do it, which is short, but use it. There's one technique that seems to have some research basis that helps, and you've probably all heard of meditation, and there's all different kinds of meditation, and a related kind of process is called relaxation techniques, some way to take your mind off of things and just focus on really what your mind is dealing with and to try to calm it down. And so if you haven't tried any sort of meditation, it's easy to find out about it and develop a process to use it. There's even a meditation technique called walking meditation. So you can try to get your mind in a meditative state as you're walking from one place to another. Relaxation techniques have to do with deep breathing when you're under stress. When you have a moment to yourself to find a way to shift your mind to something more positive. So there's all kinds of things you could do for yourself. Do they have a big impact? Maybe not big, but important. Then there's relationships that are really important. That's why I keep bringing up this burnout buddy, to find somebody you can talk to this a lot on and off. That could also be somebody in your home life. And then I'm just going up on levels here. At some medical schools, what the medical students put together for themselves, or the faculty helps put this together, especially psychiatric faculty. I think I mentioned that from the article in the newspaper, is a support group. So you might try to establish one or more support groups to meet once a week for a half hour, an hour, once every other week, whatever amount of time is helpful, just to talk with one another about what you're going through. And so that could be done without faculty. The faculty that can help usually the most is psychiatric faculty. So if some of you want to try to form such a group at your medical school, if it doesn't already exist, and there's some psychiatric faculty you already know, ask them if they can help form such a group, and maybe even be there to help it work well. And then the last thing is probably sounds the most risky or unclear about what to do, but for some larger group of medical students to bring this issue to the faculty that, you're concerned about the possibility and likelihood that you're burning out, and you'd like to talk about ways the whole system can be helpful to medical students. So, you go from the personal to the small relationship to a group, and then to the whole system. And attacking any of those could be helpful. The worst thing is obviously to do nothing and just let the system affect you as it will. So does that make some sense?
Yeah, thank you for shedding light on that.
Okay. Other questions, comments? Yeah.
Yeah, so also going off of that, how do we, for example, when the 80-hour work week like law was passed, it kind of was not actually implemented, and you know, people who wanted to enforce it or advocate for themselves to abide by it, like actually were shamed for doing that because of like the older mentality, I guess, of most people in the healthcare field. And so I guess, do you have any ideas about how we can progress that mindset and culture?
Yeah. You know, the amount of time working is a tricky, kind of paradoxical issue. Yes, the amount of time working matters, but physicians, residents, and medical students used to work more hours than we do now, actually. Was that good? Not necessarily, but as I talked to you about the history, burnout was not occurring, even though we were working as many hours or more than now. What was the bad part about working so many hours back then? You get so tired that you get what the term is called compassion fatigue. And that's different than burnout, but it's really important. You kind of lose your compassion along the way. And what you want to have as an open issue is what is the emphasis on being tough and so many hours doing that's causing harm, not only to yourself, but to patients, right? Because if you have compassion fatigue, for instance, patients are going to pick that up as you're not being empathetic to them, that you're not caring. And you would hope that faculty would realize that if it's pointed out to them, because for older faculty that's going through this, you can end up thinking, oh, what we went through was just a rite of passage and it doesn't have consequences, but it does. So that's the amount of hours, but the amount of hours is not responsible for burnout. It's how the system treats you during those hours that matters. And again, because we now know that there seems to be a correlation between burning out and patient outcome, that's what should be conveyed to everybody. This is hurting patient care. You know, the basic reason we're there to help patients. If we're burning out by how the system is treating us, we're not doing our best job with patients. You know, so it's always better to, I hate to say this, it's always better to couch problems as problems that are hurting patients rather than ourselves. Because again, when we say it's ourselves, to the higher ups, then it could be seen as, oh, this medical student is just weak, or they just need to toughen up. But if you try to put things in terms of how it's affecting patients, it goes a longer way. And that's not to say it's both, because it definitely is both. But I think to get the sympathy of the people who can solve the problems in a system, number one has to be how it's affecting patients. And so the hours affect patients as far as potential compassion fatigue and not being empathetic, and burnout does as far as effectiveness, because we know now we're not as good at helping patients when we're burning out. So it's tricky, but putting that in terms of patients goes a longer way than yourselves. And but you do have to find ways, again, like we were just talking before, to help yourself out at the same time. But if you're talking to higher ups, they'll be less sympathetic usually to yourselves than they will toward how it's affecting patients. I've tried to advocate now and then that really our number one ethical principle should be actually to take care of ourselves, not necessarily patients, but that doesn't go a long way. It'll never be accepted as the primary ethical thing. But when you think about it, we're the vehicle to help patients. And if we're not in good enough shape ourselves, we're not going to do our best to help patients. So in the back of your mind, try to think of yourself as the number one priority, even over patients, because if you're in good shape, you'll do better work with patients. Dr. Mott, go ahead. Yeah. So Chad, Dr. Moffic, how are you doing? Okay, this is a loaded question. You are just giving us advice. I feel like the attendings are always in that place looking out for students and residents and taking the extra burden. Well, I really appreciate the concern, but I'll have to tell you why I'm in a safe place now, in a good place. I'll try to do it somewhat briefly because I retired from my job at the medical school, my full-time job. I was a tenured professor in the Department of Psychiatry. I resigned from that job now, well, it's getting close to a decade ago. And why did I do that? Our system was changing. I had never heard about the term burnout back a decade ago, right? And I was telling you all, it kind of escalated among physicians around the year 2000, but even by 2012, I had never heard of the term, nor did most of my colleagues, but I felt our system was getting so oppressive, and we were down to scheduling patients for medication reviews every 10 minutes. If you can imagine that. I hope that's not in your system, but seeing psychiatric patients for 10 minutes for follow-up with their medication. Now, out of that 10 minutes, you probably had to spend 5 minutes doing your electronic health record, because that was in existence.
127.
That was in existence by then. So, I talked to my wife about how I was feeling and some colleagues and so forth, talked to my financial advisors. Did I have enough money to stop working? I was 65 at the time, and yes, I was told. So I decided to resign then. So I'm not an attending anymore, or I should say it's all voluntarily, whatever teaching I do. It's not part of my job, so that helps. And so after I was done, I was talking to an emergency physician friend who had retired, and I told him what happened. And he said, "Oh, you were burned out. I went through that too." And I said, "Oh, what's burnout?" And then I thought, okay, if that's happened to both of us, how common is it? And now that I retired from my full-time job, could I do anything to help with that? And I was mentioned in the introduction that I was part of a American Psychiatric Association wellness and burnout group, which I ended up advocating for. I became, quotes, the poster child for burnout, and did videos about what caused my burnout and so forth. And so the American Psychiatric Association has slowly but surely addressed this issue, but we as psychiatrists actually were not on top of this, even compared to some other specialties. So I'm doing okay now because I have control over how I spend my time, and I'm not constrained by any system I'm in. I kind of float around to help in different systems as I see fit. So I appreciate the question, and it was a crucial one for me to make a decision about a decade ago, but I made it, and retiring is not a solution for most people. So, that's why it's important for us to talk about these other options. Some physicians retire now earlier than they used to, or switch careers even. But you all are just starting out. You don't you don't want to have to think about something like that. You got to find ways to help make the system work as best as possible for you. So that's a long-winded answer, but I appreciate the concern.
Thank you. I appreciate it.
Okay. You know, and I never thought anything like that would happen to me. I love being a psychiatrist. I still do, but again, the system was becoming, I thought, too oppressive to work in it anymore. Other questions, comments?
Can I ask a question about the burnout buddy that you mentioned?
Yeah.
So I'm wondering, I know you said that it's possible to find like a burnout buddy to discuss these topics within like medicine, but also finding people from home. I was wondering if you could elaborate if there are like any pros and cons between finding someone within medicine to discuss burnout with, or whether like if there's like, you know, if there's any differences in terms of like where we find our like support for that.
Yeah, burnout buddy. By the way, I want to make sure I'm not coming across as too pessimistic either. You know, when I'm asked, would you recommend your child, or in my case now, my grandchild, to go into medicine, I would still say yes. I think it's potentially such a rewarding career, even with all this difficult stuff going around it. I'd still say yes. If you want to help people in that kind of way, it's still a really great career. So I don't want to come across as pessimistic either, just to be concerned about our own health. So a burnout buddy, and maybe the term is better to use buddies, not just one. It's probably better to find one within your medical school class. The main reason for that is you're kind of both going through the same thing. And so at least you have that commonality of potentially understanding and appreciating the system you're in. So if you can find one within your system, that's best. And in essence, that person doesn't have to be like your best friend in medical school or anything like that. It's just somebody who appreciates that this is a challenge and wants to be able to talk about it with somebody else. And then, you know, you just get together once in a while, or you text one another, or any kind of communication back and forth about how you're feeling and dealing with things. On the other hand, it could be a friend outside of work too. And again, that doesn't have to be, and maybe shouldn't even be like your best friend or your significant other, but just somebody to be able to focus on this particular problem. Loved ones should know what you're going through. In fact, the best system will include loved ones. And actually, my wife and I did this a long time ago. We set up support groups for spouses of medical students or significant others. So, because my wife and I were married early in medical school, so we kind of knew what it was like to go through medical school together. And so we set up support groups for medical students and their significant others. So besides what I told you about before, that's another thing that could be set up, because if your loved ones know what you're going through, meaning what the system is like and what the pressures are, and share that with other couples, that's really helpful too. So, so there's, again, it's just important to have at least one person that you could share this to. If you don't have that kind of person, what could be your buddy is your journal. One of the medical students in that article I talked to you about journaled, and journaling is really good. And you can do that. That's another thing you can do on the fly. You could chat things down on your iPhone or a piece of paper or anything. God, this is what just happened to me. And then you have that to be able to reflect back on when you have time. But when you put it down in writing, it tends to be something you remember and it's available to refer back to. So a notebook or an iPhone where you jot things down is potentially is also a buddy. That person doesn't talk back to you, but it documents what you're going through. So that's also help. I have 2 furry burnout buddies as well. Brianna says, yeah, I should have mentioned that. I mean, yeah, I mean, having a pet as a support and a loved one, so to speak, can be really helpful too. I mean, again, there has to be something that helps you, and you know it helps. But yeah, that's a great example also. I literally do tell them bad things that happen to me, my patients, and act like they are listening. No, that's terrific. That's terrific. I mean, that's another way of getting out what you feel. It's, you know, the worst thing is just keeping everything inside and not getting it out one way or another, to ventilate one way or another. But keeping it inside, you know, it just accumulates in you. And that's why one of the main characteristics of burning out is the emotional exhaustion. It just takes too much out of you to keep it all inside. So yeah, great example. Other questions, comments, more information needed? By the way, I think I mentioned this briefly, but just to go into it some more, any of you who are burning out now, by the time you finish medical school, it'll probably dissipate a lot. It isn't a chronic condition. So that's the really good part about it. You know, it's not like you're going to have a chronic depression, although depression increases also during medical school times. And sometimes you need formal help for that, right? So don't ignore real clinical depression. It's different than burnout. In burnout, you can be at work and feel satisfied and positive. When you're depressed, you don't feel that way. And there's other depressed symptoms, which you probably know. So keep that in mind. And suicide is a risk too. But burnout dissipates when the system changes or you're getting out of the system. The burnout goes away. I mean, that should make some common sense. So by the end of medical school, if you've been burning out, that should go away. But how you choose your residency, if you have some control over that, you want to find systems that seem to be concerned about the well-being of their residents. And the way to find that out is to talk about residents at schools you may be applying to. And if a medical school has a chief wellness officer, which is not real common nowadays, I think probably a quarter of medical schools have a chief wellness officer. If they do, you know that school is paying attention to this problem. So that might be something to look for. And if you don't have that kind of person in your own medical school, that might be something to try to find an opportunity to bring up.
Who is that person? Does that have to be like an attending physician? Can a student like volunteer to take on that role if your school doesn't have it? Or like, who would that person be?
Say that again. I missed some of what you said.
Who would be like the chief wellness officer at a medical school? Could a medical student like volunteer to do that? Or does it have to be like a physician? Like, how would you fill that position?
Oh, yeah. Okay.
You don't have it.
Formally speaking, it's good to be established by the administration of the medical school. Why is that? Because if it's established formally, then presumably that person has power, the power to change things. Again, presumably, because sometimes they're just window dressing, but they should have the power to make changes. And it actually could be physicians from most any specialty. Probably the most common specialty is psychiatry, but it doesn't have to be a psychiatrist. And so that person's for the whole medical But, like everything else, there's informal leaders besides formal leaders. So some charismatic medical student or resident or faculty could make wellness a project and make that a project informally. So, you don't announce, I'm a chief wellness officer now because I say so, but you take it as a problem and you work with it. And if you're charismatic enough and have good ideas, people will become interested and follow you. And that's, again, that can range from setting up support groups to bringing in an expert to talk about it to your class, all sorts of things. So informal leadership about this can be really important also, especially in a school that does not have a formal wellness officer.
I also have 2 questions, but I don't know if we have time, Dandy.
You can ask them. I'll try to answer them fast.
Pooja, you can go ahead and ask those questions.
Okay.
Yeah.
So you were talking about the wellness stuff. So I feel like wellness has been a bit of a buzzword in residency.
Yes.
And it kind of seems more like something to check off or like say that you have, but it's not truly like anything, because as you were saying, the issue is systemic. And so getting an extra day off here or there isn't going to really change anything. And so I don't know, just what are your thoughts on that?
You're absolutely right. It's more a buzzword than anything else. It's another term that sometimes uses value signaling. We're pretending that we're concerned about wellness. Nevertheless, personal wellness is still important. So you also do want to do anything you can for your wellness, whether that's what you eat, exercise, your own health, and so forth. That's still important. So yeah, but be guarded that that's really a solution to this. It's not. So, if a medical school says, oh, we have a wellness program and that's taking care of this burnout problem, it's not. Because like you said, it's a systemic issue, and it could be a way of just saying you're doing something, but that's not it.
Okay, well, thank you. I think we have the next speaker waiting, so I won't ask you a question, but thank you so much, Dr. Moffic. We really appreciate this.
Yeah, thank you all. And thank you for the opportunity. I think I've been doing this with different PsychSIGN groups for maybe a half dozen years now, which is really sad that it keeps going on as such a big issue. The pandemic, of course, is part of it now, but we still got a big challenge with this. So thank you all.
Thank you. This was great.
Thank you.
Okay, take care, everybody.
Bye, Dr. Moffic.
Thank you.
Okay, so before we go into our last speaker here, or our second to last speaker, we have Dr. Wang. Dr. Wang, are you okay to have this recorded?
Yes.
Okay, awesome. Thank you. So I'll just leave it to Isaac to introduce you and take things on. I'm sorry, everybody, that you don't get a break for this one, but do this great.
If people want to take a break of 3 minutes or so, that's totally fine too. I think it's important to also on the topic of wellness and well-being.
Yes, that's true. Okay, so shall we start things up around like 11:35 or so?
Yeah.
Okay, thank you.
Come on, girls.
All right, so it's 11:36. Shall we get started on the next talk with Dr. Wang?
Sounds good.
Perfect. Okay, so I'll have Isaac start it off.
Yes, it's my privilege to introduce Dr. Wang. She'll be speaking to us today about child and adolescent psychiatry amidst COVID-19. Just to briefly introduce Dr. Wang here, she is a child and adolescent psychiatrist and clinical assistant professor in the Division of Mental Health and Child Development at UCSF Benioff Children's Hospital, as well as the Division of Child and Adolescent Psychiatry in the UCF Department of Psychiatry and Behavioral Sciences. She provides clinical care in a couple of sites, one being the outpatient clinic at UCSF Benioff Children's Hospital in Oakland, as well as the UCSF Medical Center at Parnassus Heights. She also leads the teaching clinic at Benioff Children's Hospital, Oakland, and she works with medical students, residents, and fellows. She has multiple clinical passions, some of which include anxiety, depression, and trauma, and she provides trauma-focused CBT, insight-oriented psychotherapy, and emotionally focused therapy to patients and families, along with her medication management. She also has a handful of research interests, which include medical education, PTSD, sleep, and the gut-brain axis. She looks into and investigates a correlation between mental health and gut diseases. She completed her college degree in medical school at National Yangming Chiao Tung University in Taipei, Taiwan. And then she pursued adult psychiatry residency at UC San Diego with a fellowship in child and adolescent psychiatry at UCSF before joining UCSF as faculty. Please join me in welcoming Dr. Wang.
Thank you, Isaac, for the kind introduction. Hello, everyone. It's really great to see you all on Saturday morning, knowing there's so many people who are interested in psychiatry and maybe child psychiatry as well. It was nice to hear about Dr. Moffic's talk on burnout. My presentation will resonate on that topic as well, and hope to continue and extend the topic, as burnout is definitely a huge issue during COVID, and taking care of our own well-being is crucial before we can take care of our patients. So I'm gonna share my screen with you all. Okay. So I don't have anything to disclose. And today we're gonna talk briefly about the epidemiology of COVID, acute symptoms, chronic symptoms, general impact of COVID on youth mental health, the pandemic stress and trauma-informed care, and then we'll end with mindfulness and meditation. We'll have a little bit of time for Q&A, and hopefully we'll end earlier than expected so that you'll have some time for yourself to have lunch or have a break too. So if you can log on to this website, polev.com/Wang Hohui, which is my last and first name, 640. I just wanted to, I'm curious about where we're all coming from in relate to the topic of COVID. So I have this little kind of poll, and let me know if you can see the poll everywhere question and just click on yes or no. Okay, so more people haven't been diagnosed with COVID versus people who had been diagnosed. So just wanted to understand better. Okay, they're now equivalent. All right. Okay, this is real time, kind of in real time changing as more people put in responses. Okay, we'll give it probably 10 more seconds. All right, so approximately half and half. Thank you. And we're gonna proceed to the next question. If so, were you physically or mentally affected? This is only for people who responded to yes. So if you responded yes to the last question, please let us know and share with us if you feel like you were physically or mentally affected during the time that you're infected. I want to make sure that this works for everyone. Does the website work? Okay, we'll give it, again, 10 more seconds. So yes, people were physically or mentally affected. And the next question, for everyone, have you seen or cared for COVID patients, either in the outpatient or inpatient setting? So yes, the majority of people had this experience. And the next question, and also the final question, for any patients that you have cared that has COVID infection, anyone that was a minor, 18-year or younger, just wanted to see what's people's experiences with caring for a minor that were infected with COVID. Okay, cool. The poll is still coming in. All right. Thank you for sharing with us your experience. It's interesting to know what your experience is happening, because when I was a medical student, of course, there wasn't COVID. So I can't imagine how difficult it is to complete medical education in or even training in medicine and psychiatry during the time of COVID. And we're going to talk a little bit more about what we know and also what we don't know yet, and then what we can do in the future. So going on, these were the 4 questions. So we're going to kind of just quickly go through some basic kind of facts about COVID. There are fewer cases of COVID in children compared with adults. We know that there are lower hospitalization rate in younger people. Children with special needs, such as neurologic conditions like autism or epilepsy, they do have increased risk for severe illness from COVID. So they're a vulnerable population. And some kids who have had COVID, acute COVID, may later develop MIS-C. So this is another population that we will more common see psychiatric symptoms among them. Children's infection rate is about 1.6%, so it's comparable with adults' infection rate, and it continues rising because now, as COVID have more variants, they become more contagious, and it seems like they also affect kids and teenagers more than back in 2019 or 2020 when we first found COVID. Another recent study published on JAMA recently concurred with this observation that preschool, middle school, and high school kids have higher infection rate than adults. So maybe in 6 months, the data will change again, even though now we said the infection rate is comparable with adults, but maybe who knows, it will probably even be higher in the next year. Children represent close to 20% of total accumulated infection population. So it's actually a pandemic for kids as well. When we talk about and think about the impact of COVID on children's mental health, we tend to think about it and divide it into 4 layers. So from the most imminent to the more kind of vast and general, we talk and think about the illness itself during the acute and chronic phase. And then we think about what is the treatment and hospitalization doing to the children, the imminent isolation and the fear of treatment and staying in a hospital. And then we think about what's the family's responses. There may be grief or loss of a family member, the sadness, the grief to the children, and it may be stressful to the parents' emotions and well-being. And then lastly, we think about the societal responses to the whole lockdown and COVID precautions, and how does that impact kids and youth's mental health, and how do they react to that? So here are the symptoms that we see in children. This is what I extracted from CDC website. You can see these are pretty similar with common cold or a flu, that fever, fatigue, headache, myalgia, cough. None of that really is psychiatric. So during acute phase of COVID infection, actually, it's really rare to see neuropsychiatric symptoms. You may have heard of this term, MSC. Sorry, I saw that there's a question coming in. We'll address the questions at last, but feel free to text that in comment or the chat area. So you may have heard of the term MSC, multisystem inflammatory syndrome in children. It happens usually within 2 to 6 weeks of acute COVID infection. It affects mostly school-age children, so we actually see it most commonly among 8 and 9 years old. And the syndrome had also been seen in infants and young adults, but just not as frequent. The syndrome usually starts within 2 to 6 weeks, but on average is 4 weeks after the acute infection. We have seen encephalitis, seizures, meningitis, and confusion in about 20% of these cases. There have been a small scale case series showing that there are antineural antibodies found in CSF in these kids with subacute neuropsychiatric symptoms. So we do see that there is a correlation of antibodies in CSF, and they do present neuropsychiatric symptoms, but we haven't established a causal relationship. So still it's unclear why and whether subacute COVID infection would manifest in ways of neuropsychiatric symptoms. You may also have heard of a term, post-COVID conditions. Some people call it long COVID, or some people call it long health. This is an umbrella term for the wider range of health consequences happens 4 or more weeks after infection. It may be new symptoms that are totally irrelevant to the acute phase symptoms, or ongoing symptoms that started during the acute phase. They're less common in children. You may have seen or heard of it more in adults, but they do still occur. The most common ones are tiredness and fatigue, headaches, insomnia, trouble concentrating. So you can see there are some neuropsychiatric symptoms that start coming up when people are in this post-COVID phase. And here are a collection of post-COVID symptoms. So I marked the ones that are psychiatrically related in orange color. And there are a lot more compared with the last slide when we just look at the acute symptoms. In a recent study, the researcher also found close to 50% of kids who recovered from COVID reported at least one persistent symptom after 120 days, with close to 50% of them reporting symptoms such as insomnia, chest pain, chest tightness, fatigue. So this is definitely something that we will continue to see. And then I think a lot of people are researching into this, but we still don't know the direct cause or how to treat them. A lot of that is really just symptomatic treatment and support. We'll talk a little bit about the overall impact of the pandemic on mental health. So there are emergent evidence that acute, subacute, and chronic illness cause psychiatric sequelae. There are definitely stress from treatment and hospitalization. In the past, during the last SARS pandemic, there were a lot of studies showing that kids can suffer from anxiety, fear, and depression during the acute treatment, and it's similar with the current COVID pandemic. There are a lot of grief from losing loved ones, even despite kids are not at higher risk of death and severe illness compared with adults or older people. But a lot of them had lost their parents or grandparents or their caregivers during COVID. So the bereavement have been a rising issue. The COVID pandemic and lockdown also result in higher rate of anxiety and panic attacks, fear, irritability, and depression among kids because they can't go to school and they entirely lost their social life. And of note, children of racial and ethnic minority families also have much higher risk of losing their caregivers to COVID. So they're a vulnerable population in the pandemic. In another study, 80% of children were found to be affected negatively by the pandemic and quarantine, and this is not surprising at all. We can imagine how difficult it is to almost all the children. A third of them were found to be suffering from various psychiatric symptoms. And these symptoms had a wide range, overlapping with existing psychiatric disorders, such as anxiety, PTSD, ADHD, or even behavioral disorders. About 10% of school-age children had more severe symptoms that would create conflicts in the family because of their behavioral outburst. In this research, in this study, they found that physical exercise helps reducing behavioral problems in children and improve the relationship between kids and their parents. I think what's interesting is, as a child psychiatrist, we can emphasize more how important it is to communicate with parents and actually teach them tools besides teaching the kids, because a lot of our patients' anxiety, a lot of the children and teenagers' anxiety actually come from their parents' anxiety. So it's important to teach the both parts and so that they can help each other. So close to 50% of caregiver also develop anxiety and depression during the time of pandemic because of the lockdown and being so close, everyone are just cramped in the house together. Besides the anxiety and depression during COVID and during the lockdown, as we're kind of being back to normal again, this normal is a new normal. It's not the old normal that we were used to. My colleague and I created this video to share some tips with parents and kids and teens about kind of 5 different techniques that they can use to help them going back to normal.
Preparing for the next school year, some things that might help are: 1, resume activities at a gradual pace, particularly for children and teens feeling nervous about a return to in-person learning. Starting small now can build confidence and ease the transition back to in-person school. Socializing with friends and teachers is a huge benefit to in-person learning, but can also feel scary after a year away. Scheduling hangouts with friends or family and returning to other activities, in line with CDC guidelines, of course, can help. 2, talk about precautions your school is taking. There may be things about school that are different to promote health and safety, like confirming you feel healthy when you arrive on campus, staying home if you have any symptoms, wearing masks and physical distancing. If your child has special needs and struggles with transitioning between settings, consider writing your concerns down to discuss with school. Support with visuals and other tools can also help. 3. Before school starts, create a sleep routine and schedule that is in line with when you'll need to fall asleep and wake up for school. We all have a harder time when we're sleep deprived. Giving yourself the gift of sufficient sleep is a well-proven way to feel more calm and regulated during the day. 4. Develop a consistent routine and schedule. There are many things that remain uncertain about school next year. None of us have a crystal ball. Developing daily habits can help increase certainty about what you can control. One benefit of in-person learning is that structure and supports are built into the school day, so you don't have to do it all on your own. 5. Communicate. Talk as a family, talk with your school team. We know that many concerns may have slipped through the cracks during this past year, but if you have concerns about learning, ask your school about what supports they can provide. As a parent, you have a right to request that your child be assessed for accommodations and special education services through the public school system. These services are designed to help children who are struggling because of learning differences, challenges with attention, or a variety of other emotional and developmental differences. Above all, take care of yourself. If you notice changes in your mood, anxiety level, sleep, or appetite, talk to your caregivers, pediatrician, or school counselor about meeting with a licensed mental health professional.
So those are some tips for parents. And I often feel I can use, as a provider, as a psychiatrist, I can use a lot of those skills too myself, because it's really important to make sure that we put ourselves on the oxygen max first before we can help the children and teenagers that we help. So as COVID-19 becomes chronic, and most likely we're gonna live with it for the next couple of months or even years, we should really see it as a traumatic event. This graph of phases of disaster becomes useful when we're looking at COVID-19 as a chronic disaster that continues to impact our day-to-day life. So the whole societal mood really goes through the ups and downs during COVID or any disaster. In the beginning, people move from a neutral state to kind of a really pump up state. That's what we call the honeymoon. People are really working together, trying to defeat the disaster and believe that we can take this, we can do this if we just work together. Over time, when we realize that it's really not what we had imagined and it's difficult to contain, people will go through the kind of whole societal mood, will go through the a really down state. And then over a year, that's usually the time when we have a more consolidated, realistic take on the current disaster and step into the reconstruction mode, which is what we're in right now. So it's moving from the neutral state to a kind of a pump up elevated state, and then going through a more kind of depression, overall depression, general depression. And over several months, people will kind of gradually shift back to neutral again, the neutral state again, and to be ready for the reconstructing work. The reason why we talked about looking at it as a disaster and looking at it as a traumatic event is because what COVID do to us as a society and as medical providers is we are seeing our patients and ourselves going through the chronic stress, to have the chronic stress response. When there's a stressor, what it does to both the sympathetic nerve and parasympathetic nerve is it keeps stimulating the sympathetic nerve. And over time, they're just inadequate proprioception of completion. So our sympathetic nerves cannot recover to its normal state anymore. And we're just constantly at a slightly elevated state. Our cortisol is higher, and over time, the body, the muscle tone just wouldn't be able to return to normal. And similarly for the parasympathetic nerves, over time, because the stressor keeps hitting our nervous system, so there's a diminished vagal tone, and over time, the vagal tone will just not be able to reestablish back to its original state. And having that in mind, we're also introducing trauma-informed care for COVID response. When it's very common that parents come into my clinic and talk about how terrible their kids have been doing during this time, how much that they're screaming, arguing with their siblings and running around in the house, not doing their homework. And through a trauma-informed care lens, it's really shifting our perspective from what's wrong with you, kid, to what happened to you, because what happened to you is really looking at this is hard for them, and the whole lockdown, not being able to go to school, the whole connection with their friends and peers were just cut off, is really not what they wish for. And they're just all trying to do the best they can. And the eventual goal of trauma-informed care is to be able to shift that perspective further to think about what's right with you. Because these kids' behavior might actually be a cry for help. They're trying to not just hold it within themselves, but also trying to communicate with their teachers and parents in a way that I need help and I miss my friends, because they're friendly and loving people. They care about their friends, and that's the reason why they're acting aberrantly. So it's shifting from what's wrong with you to what happened. The disaster is really taking a toll on everyone, to what's right with you, because we really do care and we love our friends and relatives and families. So that's the reason why they're having a hard time. And I also want to share the 6 stress busting strategies. This was released in 2020 by California Surgeons General to help target stress during COVID-19. This is sort of similar with the last burnout talk. There are many different things that we can do to help with our well-being, including balanced nutrition, mindfulness practices, regular physical activities, sleep, supportive relationship like having a burnout buddy, and mental health care. I want to especially emphasize the importance of mental health care and mindfulness practices. It's really imperative to be aware of our loved ones, and our patients' mental health. Video visit is a perk emerging during COVID. If we try to think of anything good that COVID had brought us, it eliminated the burden to psychiatric care for a lot of people who had no access to be able to get to a medical clinic. Virtual treatment of psychotherapy, psychiatric care, and even substance use disorder treatment all become possible this way. And even for people who do not have a regular appointment, they can still arrange intake, because video visits are just becoming so prevalent nowadays. The other thing I want to share is the importance of mindfulness and meditation practice. Mindfulness is the attitude and belief, and meditation is the practice helping us achieve mindfulness. Practice mindfulness activities such as meditation, yoga, or prayer for 20 minutes for about 1 to 2 times a day is similar with hitting the reset or restart button for us. And there are a lot of apps like Headspace and Calm are easy, accessible way to get started. They now often have promotion too. So when you see one, I'll definitely recommend you to try it. There are other plentiful resources on YouTube or Netflix. For beginners, I highly recommend this 8-episode series on Netflix called Guide to Meditation. It's this left upper one. If you have Netflix, try to find it. It's 8 short episodes, and it's very nicely done, introducing meditation and guide you through how to do it with visual and audio cues. Mindfulness can help strengthen the brain pathways that actively buffer the stress response. So it can help with the sympathetic and parasympathetic nervous responses that we talked about earlier, and then help us to regulate our stress response more easily and helping to be kind of reinstated back to the normal state. You may also have heard of MBSR and MBCT, which stands for mindfulness-based stress reduction and mindfulness-based cognitive therapy. Both have established their efficacy in various psychiatric disorders, including anxiety, depression, sleep, trauma. And there are emerging research of these treatment modalities in helping people cope with the ongoing stress with the COVID pandemic. So lastly, I wanted to share with you a kids meditation that I love to do with my patients and medical students and residents and fellows. So feel free to turn off your audio or video, or you can keep them on if you feel comfortable. But this is a butterfly body scan. It takes about 4 to 5 minutes. So this is our last activity together. We're just gonna do this meditation and then we'll kind of review what we had talked about today and then have a Q&A.
Body relaxed, resting your hands on your knees. If you're lying down, lie on your back. If it's not comfortable, you can open them at any time. Now think of a butterfly and picture it in your mind. What does it look like? Is it light as a feather? Is it heavy? It can look exactly like you want it to. Mine always seems to have blue and purple wings. Do you have a picture of a butterfly in your mind? If you need more time, or if you want to share what your butterfly looks like to a friend or grown-up, just press pause. And don't forget to press play when you're ready. Let's pretend that your butterfly has special powers because it helps you relax different parts of your body just by landing on them. Let's give it a try. Imagine that the butterfly is flying nearby and it lands on your forehead. And when it does, your forehead feels warm and your muscles relax. Imagine the butterfly floats off to one shoulder. And as it rests there, your shoulder starts to feel pleasant and warm, and it relaxes. And now to the other shoulder. As the butterfly lands there, what's happening? Does your shoulder feel warm and pleasant? And does it feel relaxed? Are you ready for the butterfly to move? Imagine that the butterfly floats off your shoulder and lands on your belly. And as it rests there, lightly moving its wings, your belly relaxes. And as you continue on your own, imagine the butterfly floating through the air as it finds its way to your knee, or maybe even one of your toes. You can imagine the butterfly landing anywhere you like, and wherever it lands, that part of your body feels warm, comfortable, and completely relaxed. For a few moments, relax with your butterfly and feel the steady rhythm of your breathing as you breathe in and out. You can put your hand on your tummy or over your heart if you like, and feel the movement of your breathing. Now open your eyes and feel your body on your seat or against the floor. And if you're lying down, sit up slowly and stretch. Reach your hands high up to the sky and take a big breath in. And then lower your hands to your knees as you breathe out. Well done. If you'd like, you can name your butterfly and invite it to visit you again soon.
Okay. So lastly, the take-home messages, COVID-19 impacts children and adolescents both mentally and physically. Acute symptoms directly related to COVID are rare, but subacute and chronic symptoms do occur, especially in people who have MIS-C and long COVID. There are tremendous impact to families and society, and their higher overall rate of various psychiatric symptoms among children and parents. In summary, this is a stressful time. A lot of the things that we have taken for granted forever have shifted, and the sense of permanence and predictability is gone for adults and children alike, which is the reason why there are these anxiety, depression, various psychiatric symptoms that arise. The silver lining is there are a lot more focus on personal well-being and the delivery of psychiatric treatment and innovative technologies such as telehealth, video visits. Children are in particular are focused during this time because they grow up in such a challenging time when they're the most vulnerable. And the key is really to engage both the kids and their family, their parents and caregivers, and provide them the tools so they can adapt and healthily thrive. So I saw that there was a question earlier, and I was in a mode that I wasn't able to read the chat. From Caitlin, can you cover the impact of lockdown and school closure on kids? I think there's a slide that we talked about this, that yes, there are tremendous impact in many different ways, and a very large number of children were affected negatively. And I think what's interesting is parents are even impacted more severely than kids in these surveys, because parents also feel like they're really fed up with being the kids' parents and cook and teacher and nanny and everything. So both in my clinical experience and what we have read on kind of those research literatures, it's really important to provide tools for both parties so that they can grow and thrive together.
So Dr. Wang, I have a question in regards to something like that. I find that kids are very perceptive. They're able to gauge people's emotions really well. So when parents are suffering from either anxiety, depression, PTSD, bereavement, whatever, I don't know if you mentioned this, but do you see often in your practice that kids are affected from what their parents are experiencing it, and do they communicate that with you, or?
Yeah, that's a really good question. And generally speaking, kids have anxiety and depression from parents' anxiety and depression even before COVID. So sometimes they need to be, when we see the kids present with anxiety and depression, we also in our first evaluation, we access parents' own anxiety and depression and whether they're getting treatment. So that is definitely one part of our evaluation, and we will prescribe or recommend the parents to get their own treatment as well, or sometimes family therapy, so that the kid can communicate their feelings to their parents, because a lot of kids will feel like my parents are sad because of me, because I'm bad, or I did something wrong. And that's very natural for kids to feel that way, but it is hard for them or scary for them to bring it up to their parents. So a lot of times family therapy can be helpful, and parents' own medication or therapy treatment will be really helpful too. Yeah, great question. And there's another question from Brianna. Can you talk about how long you feel it will take to make up missed milestones? For example, kids with limited PT, OT speech or early intervention programs, infants looking at mask and feeling of developed social smile, etc. That's a great question. And I think there are also research that are looking into these things, because there was almost a year or 18 months gap for a lot of our patients to get any kind of evaluation or treatment. We might never be able to make up for that. It is just sad. And I think the silver lining is we used to think that it's not possible to deliver any PT/OT or speech therapy over the internet. And I think because it has been almost 18 months that we weren't doing anything for kids with special needs or younger kids that needs these therapy. So we are kind of forcing ourselves to go into this territory and then try out different things. So it's very common that we do PT/OT and speech nowadays over the internet and do it via Zoom. So it's kind of standard practice, at least at UCSF. And I know, as far as I know, a lot of other programs are doing the same thing as well.
So I'm a third-year student, and I'm strongly considering applying to like PsychSIGN. Is there anything that like I can be doing now to like help children? Like any place where you identified a need where maybe we'd be able to get involved to kind of help kids who are transitioning back to school, or to bridge this gap that's missing because of the impact of the lockdown?
That's a good question. So you're thinking of triple board programs?
Yeah, that's what I'm looking into right now, like the triple board programs.
Yeah, no, that's great. And I some of my best friends are triple boarded psychiatrists. I don't particularly know any programs that you can apply or volunteer at, but I'll recommend you to look into kind of locally and your university and institute, because I do know what we can do at like San Francisco Bay Area and UCSF, but I don't know if it applied to everyone. There are always opportunities, I think, locally in your own program if you reach out to child psychiatry division, because I think the triple boarded psychiatrists are so flexible. They can easily work with either pediatric or psychiatry. So that's a really big advantage, because you can reach out to both programs, and that would expand a lot more opportunities. Another question, have you observed any differences in terms of psychological or behavioral issues in kids since the increased use of technology for school during COVID? Yeah, so AAP used to recommend no more than 2 hours of screen time for school age children. And of course, this is like a slap in our own face, because everyone is using screen over 10 hours now when kids are not at school and then trying to do the education online. I think the psychological or behavioral issues are increasing, especially a lot of school age children started watching porn, and that has been a kind of an epidemic during COVID pandemic. So there have been different kind of family educational sheets released by AAP, the American Academy of Pediatric, and ACAP, the American Academy of Child and Adolescent Psychiatry, about how to supervise children on using technologies or using their computers or tablets. I think there are a few key things. So first, it's impossible to reduce the screen time now, because a lot of school settings are still not back to 100% in person. Second, while living with the reality that your kid will have a lot more access to phone, tablets, and computer compared with 2 years ago, it's important to have supervision. So if the screen use is supervised, then it at least will do less harm to the kids, because when it's unsupervised, they will most likely view different websites that you don't want them to, and it's really hard to control and filter out what they're looking at. the other thing is we do recommend family to install softwares that they can monitor the usage. And then some of the softwares can even lock the tablets or the screen at a certain time, like after 11 p.m. We also recommend taking away the tablets or the computer after bedtime, because kids will not be able to regulate themselves and not waking up in the middle of the night and watch whatever they want to, and then not sleeping. So it's another crisis during COVID, because the technologies can be helpful, but on the other side, it can be harmful if it's unsupervised.
I had a question. Are there, or have you seen in your own practice certain populations, pediatric populations, that seem to be affected more by the lockdown? I'm thinking of perhaps children with autism or other subgroups.
Yeah, great question. And we do see that clinically. So kids who have very severe autism or developmental disorders tend to do better during COVID, because it's really hard for them to get out of the house or even to adapt to the outside world. But kids with milder forms of autism and developmental disorders will be impacted more, because it's helpful for them to get out of the house and get services. But a lot of these services were discontinued during COVID, as we talked about earlier. For kids who have ADHD and irritability, they're impacted greatly, because during lockdown, everyone is kind of just cramped in the house, and there are very limited space for everyone to kind of see each other 24/7. And it can be really triggering to the parents, and parents' responses in turn being triggering to the kids who already have irritability or ADHD or other behavioral problems. So these are kind of the two populations that I think are affected the most. So kids with kind of behavioral outbursts in ADHD or other irritability related disorders, like impulse control, or kids who have milder form of neurodevelopmental disorders, because they can go to the special services or go to their school, where was usually the place that provides special services for them. And their parents or caregivers are not well equipped with the skills or even the devices that can help them with studying. All great questions.
I also have a question related to that. So what are your thoughts on how the lockdowns like differentially impacted kids? Like some schools stayed open in certain states, whereas others didn't. And so now we will have like a generation where with severe like developmental incongruities, I guess.
Across states or kind of nationally. Yeah. I think that's an interesting question to think about. And to be honest, I don't know, because we're in California, and during COVID, I also have seen patients virtually of other states. And there are some states that have very different regulations in terms of COVID lockdown and precautions. So I think it's important to just stay curious about where they're coming from, what's their thoughts on COVID, because I think people can think and react very differently for people who live in different areas. It's also important to know what is their local precautions, because they may be following all the precautions or regulations of their local area, but to us, we may just think very differently. I believe that it will be a research topic in the future, because I haven't seen anything that we have. I don't think there have been any, as far as I know, research that have been published regarding how this impacts the nation and all the states differently, since we have very different views almost in every different area.
Thank you.
Okay, we can also end a little bit earlier so that you have some self-care time. It's really nice to meet everyone, and potential psychiatrists and or child psychiatrists in the future. We need you guys. It's good to see you all.
Thank you, Dr. Wang, for just taking the time. We really appreciate your talk. I know it's stimulated a lot of great conversation. So just thank you for taking the time on your Saturday.
Absolutely. And you all too. Bye.
Bye. Thank you.
Thank you so much. Thank you.
Okay, so we'll probably get started on our last speaker soon, maybe around 12:30 or so. So y'all can take a little break before we begin our last talk. Okay, thank you.
Hello, Dr. Starks. Thank you so much for joining us.
There, how are you?
Good. Just wanted to let you know everyone's taking a 2-minute break.
Oh, it's no problem. Looks like y'all had a great program or have a great program on board for today. So nice to see.
Yeah, hi, Dr. Starks. This is Danby. I've been communicating with you. Thank you so much for being here. Feel like we're going out with a bang, so we're excited to have you.
Yeah, glad to be here.
Okay, so now that it's 12:30, I think we can just begin our talk. I'll leave it to you, Megan, Ivan, to take it off, okay?
Sounds like a plan. Dr. Stark, before we begin, just want to quickly double check with you. Is it okay if we go ahead and record your talk today?
It is, yes.
Okay, awesome. And without that, let me go ahead and begin. So Dr. Stark, thank you again for coming to speak with us today. So for everyone here, Dr. Stephen Starks is a clinical associate professor over at University of Houston College of Medicine. He earned his medical degree from Louisiana State University and then completed residency in psychiatry over at Baylor College of Medicine affiliated hospitals, and then further completed a clinical fellowship in geriatric psychiatry at Yale New Haven Medical Center. He's also completed training in health equity and health policy, and his research and work focuses on advocacy in addressing racial disparities in medical education, organized medicine, and mental health. He has held multiple positions in the nation's health policies, such as the 2011 to 2013 APA Diversity Leadership Fellow, the Board of Trustees Ad Hoc Work Group on Strategic Planning in 2014 to 2015, and in 2018-2019, he was the Health and Aging Policy Fellow and American Political Science Association Congressional Fellow. Alongside his advocacy work, Dr. Starks appreciates opportunities to mentor and advise students, residents, fellows, and peers. And since then, he's joined APA since he's joined APA in 2006, he served in various roles, including regional co-chair of PsychSIGN, advisor for the APA Fellowship Mentorship Program, and advisor for the Black Men in Psychiatry Early Pipeline Program. So once again, we have the pleasure today of introducing him as he discusses the intersection between structural racism, mental health inequities, and COVID-19 pandemic. Take it away.
Thank you so much, Ivan, for that introduction, and so excited to be a part of this program. As you heard in the introduction there, I was a regional co-director for PsychSIGN Region 5, so it's exciting, again, to see all the great work that you all continue to do. Yes. Very kind of exciting and looks like a very organized program here. So I hope you're enjoying your time, and I hope you all are enthusiastic about what your future holds for you all. So yeah, I remember being in your position not so long ago. I guess longer than I thought. I'm going to share my screen here, and for today's presentation, I definitely kind of wanted to make sure that this was interactive. I'm sure you've been, this looks like this is the end of your program today. So I hope our discussion today kind of is meaningful and also it's an important conversation. I appreciate the fact that you all had intention about developing a program tied to COVID-19. Obviously, it's has affected our country, our healthcare system in a number of different ways past, nearly 20 months now, and it'll obviously have lasting impact, specifically as it relates to mental health. One of the concerns that I had earlier on when the numbers of COVID cases were rising and people were affected by severe illness or affected by death and loss is thinking a little bit about the mental health response that would result. So the traumatic response for people losing their loved ones or being ill, and the devastation that it would continue to leave specifically on those communities that have been historically marginalized or made vulnerable, those that were most impacted by COVID-19. My topic of discussion today will be partly tied to the policy paper that was shared on COVID-19, structural racism and mental health inequities, a paper and article that I'd written with Dr. Ruth Shim over at UT Davis. It's been very kind of interesting to kind of watch our particular work kind of roll out. It was probably completed, written or submitted last fall and rolled out in terms of a policy brief this spring and published last month in Psychiatric Services. And so I've had a lot of opportunity to not only think about the work, but kind of where we have evolved and where our country has gone since the pandemic began. So this is the brief here. It was a part of the Think Bigger, Do Good policy series that was organized by 4 foundations that are based in the Northeast and Midwest, 4 foundations who were very intentional about developing policies and creating meaningful programs that are sustainable, that target issues pertaining to mental health. So the Scattergood Foundation, PEGS Foundation, Patrick P. Lee Foundation, and the Peter and Elizabeth Tower Foundation. Their partnership with Psychiatric Services kind of allows for their work to expand not only to the community, but also within academic medicine. Just to introduce the topic, since it's somewhat of a novel term, syndemics was a way for us to really kind of establish the core and to really think about what was going on at the time. So I know it's been a long and very disorienting year and a half, but think back to the beginning of the pandemic, think back to February, March, April, May. At the time, we, didn't have a lot of information, obviously, on the broader impacts that were to occur tied to the pandemic. But we did know that communities of colors would be particularly vulnerable. The term syndemics has been around for a few decades now. It was developed by Merle Singer, who is an anthropologist, a sociologist, who studies the impact of societal and political factors on health. And so syndemics in itself is just synergistic epidemics. And how he described it is the concentration and deleterious interactions of 2 or more disease or other health conditions in the population, especially as a consequence of social inequity and the unjust power of exercise. And in syndemics, the interactions of diseases and other health problems commonly arise because of adverse social conditions that put socially devalued groups at heightened risk. In his term, the term that he coined was actually established back when the HIV/AIDS crisis was going on in the early 1990s, and has also been used to kind of identify challenges globally tied to the disease states associated with tuberculosis and other infectious diseases. So it had broad applications, and as a term that it had kind of somewhat kind of picked up, but more recently, given the crisis of concerns related to COVID-19, was kind of expanded and used a little bit more, and kind of clearly identified some of the things that we witnessed in last spring. And one of those things, and you might recall when the first news cycles and clippings were coming out, there were descriptions about certain epicenters across our nation. So whether that be New York, Brooklyn, or New Orleans, or Detroit, or Los Angeles County, or Philadelphia, we were hearing kind of the news media kind of present and frame the issues pertaining to the pandemic, identified as tied to racial and ethnic minorities. At the time, there wasn't a lot of discussion about, why that was. The only thing that you tended to hear in the news cycle was that, these groups tend to have more pre-existing conditions. And so really kind of dismissing the other factors, political factors, like structural racism or the economic vulnerabilities that exist within these groups historically that really kind of lend to it. So it wasn't until maybe later in the summer where you started to hear a shift in the direction of why this disease, this virus was impacting communities of colors in the large numbers that there were. And tied to that framework itself, because sometimes if you easily dismiss those socio-political factors, you tend to kind of focus your efforts on improving things like the pre-existing conditions themselves, or improving things related to precautions tied to COVID-19, but much more difficult to correct or to really reform our policies that exist in our health system tied to racism, or tied to the other socio-determinant and political factors associated with the issues that we see in our mental health system. One thing I'd like to say about this particular article, and our intention again was really, it's a policy brief and really kind of pushing to propel specific reforms in our systems. So whether that be on the local level, state level, community-based, and really the federal government. So at the time we wrote this, we were really kind of looking to kind of impact change and to really communicate with policymakers about some of our concerns at the time, and really trying to identify specific target groups that reforms could occur within. So we came up with these 8 policy recommendations, trying to kind of keep it simple and not be overly expansive, but to really target what we had seen at the time as kind of some of the top and kind of high level areas that really needed to be impacted. The first of those was tied to protecting essential health workers, essential workers broadly and other vulnerable populations, to empower and engage communities, to think a bit more about optimizing community-led crisis response interventions, to improve data collection and dissemination, specifically as a tie to COVID-19, to support school-based interventions, and to expand financial supports for mental health service delivery, to expand insurance coverage and increase access, and finally to promote workforce diversity. So I'll try to touch upon each of these points in the next few slides. And please feel free, again, we can have Q&A at the end. I'm looking at the PowerPoint and not your faces. So if you have any questions, please unmute yourselves and speak up. I'm okay with interruptions during the presentations themselves. So the first area that we really wanted to focus on is, again, thinking about protecting essential workers and other vulnerable populations. At the time, the data did suggest that communities of color were more likely to be engaged in in the role of essential workers, and more likely, again, to be somewhat on the front lines, kind of providing essential roles actually in the healthcare workforce. So when we think about nursing assistants, licensed practical and licensed vocational nursing staff, kind of other kind of support staff on hospital sites, whether that was tied to supports for cleaning and maintenance, or whether we talk about kind of broad use of those who work in jobs related to transportation, public transportation specifically, communities of colors, racial and ethnic minorities, Hispanic, Latinx, African Americans are more likely to be engaged in that type of working environment. And so thinking specifically for the challenges, or thinking specifically about the challenges that those workers face, specifically when it comes to their health. So thinking about their access to employee and sponsored insurance, really making considerations for their ability to take time off for sick leave. So again, while some employees may have easy access to those who are, having employed in jobs that their salaries are less, make a lower hourly wage, don't always have the same access to certain types of benefits, nor do they have the luxury of being able to take time off to tend to their healthcare needs or the needs of their other family members. So really kind of thinking a little bit about how vital it is, again, to protect those at higher risk, and also to think about prioritizing, at least at the time, their access to protective care. So being mindful about their access to PPE was one of our big concerns, and one thing that we wanted to ensure that we supported. Next was really kind of in line with engaging and empowering communities. And that itself was really kind of tied to the disconnect that I think we all heard in the media. So communities themselves were responding to their own needs. They weren't having the same access to local and state programs, and the communities themselves were recognizing their challenges in really kind of supporting and protecting their needs of their community members. Community-based organizations also tend to do the bulk of the work. So I think you may be aware, just in your limited experience, maybe on some of your clerkships and other clinical experiences, that health systems, clinics don't always easily partner with community members. So it's up to community-based organizations, nonprofit organizations, to really support the needs of their community members. The idea behind this particular policy recommendation was that oftentimes, especially when we talk about the federal emergency response and the state response at the height of the emergency, those funds supported supplies and resources that were delivered typically through county departments of health, state departments of health, but oftentimes there was a disconnect between community-based organizations who provide the immediate and direct needs to community members. So the idea behind this recommendation was to, again, submit those resources and those funds directly to community-based organizations in order to best intervene with community members that they serve. Next was really kind of the idea behind what was, in addition to what was going on in terms of the COVID-19 pandemic, what was to think a little bit about its overlap with what we saw in last year's social justice movement. So thinking about the impact of the excessive use of force that we saw with police, with the murder of George Floyd and other persons of color last year, and thinking again about kind of more adequate response of law enforcement to community members who were in crisis, and responding to their needs in appropriate ways. Thinking a little bit about crisis responses. So when someone does call 911, thinking about what training and support law enforcement has specifically to deal with individuals in mental health crisis, whether it be those in an acute mental health crisis or those with chronic severe mental illness, who oftentimes the first point of contact for them receiving access to health services is oftentimes through police force. So thinking a little bit about kind of how to broaden non-traditional responses. You may have all kind of heard about the work of the Hohui program. So kind of a program that was developed in order to kind of implement a mental health crisis response that did not involve law enforcement. So to really kind of help clients and individuals in the community to receive the appropriate type of interaction and response, and one that was less likely to escalate in terms of increasing a risk of harm to an individual, or that would prevent, obviously, a lethal response from perhaps there being a miscommunication or a situation where kind of the context was lost in translation, and police and other law enforcement officials would inadequately respond to the need of someone who simply needed support for their mental health disorder or illness. The next portion was really kind of tied to what we knew and didn't know at the time. So you all might have been aware at the time of the questions that people had about what type of data was collected, specifically when it came to contact tracing and understanding the impact of COVID-19 transmission on certain communities. Many of those systems in various states did not track data tied to race or ethnicity. And why that was important, or why that is important, is again kind of directing interventions and thinking about public health, community health, preventive responses in those situations. There were outside groups that were tracking it. So there was a COVID-19 racial data tracker that was kind of developed in an academic kind of setting. But again, that's not anything that could truly sustain a local and state response to what was occurring last year. So to really kind of improve kind of data collection is to kind of meaningfully and intentionally direct services through county and state sources to effectively track that data. And again, having the difficulties in tracking that data oftentimes, I think, led to maybe some of the challenges that we see now in terms of the vaccine rollout and the hesitancy, or what we like to describe as the vaccine inquisitiveness. So questions that certain communities, certain individuals still have kind of related to COVID-19 vaccination and other responses. Tracking didn't get any better as a result over the course of the past few months. And I think there has been kind of less intention and focus on it lately, but still an avenue that would be incredibly important. Again, hopefully we're having less issues in terms of breakthrough cases and less need to track as vaccination rates have improved across variable states, but I think some states are more challenged than others. I'm here in Texas, you're in California, where the rates are much higher. And so I think there's still kind of a need to support and improve data collection and dissemination of that information. The next idea was really kind of tied to our concerns about what was happening in terms of schools. So we had our stay-at-home orders that were implemented last summer. As some of you may be aware, school-based mental health services are where many kids, specifically those who may be economically challenged or disadvantaged, receive and access their mental health treatment and support. So school-based interventions were particularly a challenge last year when folks were not on site. There are kind of some novel interventions that could have been aligned to it. So again, we all know that many students were participating in school virtually. And so the idea behind this particular kind of policy intervention was really looking at avenues to provide telehealth services and telemental health services to students who need it, specifically those students who may have severe emotional disturbance and who may have been impacted by COVID-19 either due to environmental changes, so the economic instability of their parents, which may kind of contribute to stressors at home, or in terms of the lack of the social supports and community that they had in a classroom setting. So tending to be a little bit more isolated and away from ways to kind of cope and manage their own distress or their own fears and anxiety related to concerns about transmitting COVID-19 to their family members. There, again, were not, there in general are not a lot of school-based interventions that were in effect beforehand. In some cases, telehealth services and expanses to telehealth access could have been a big, had significant impact on these communities. The other challenge, though, with these types of telehealth services is, again, we know that there are differences in a digital divide. So we know that certain communities don't have access to a broadband infrastructure, and certain students and those participating in school may not have access to high-speed internet, Wi-Fi services and so tend perhaps to use cellular or data in order to kind of connect with care. So again, thinking again about a broader approach in really targeting the needs of several members across the life and development spectrum was the kind of important impetus behind pre-support for school-based interventions. And then next, in terms of really thinking about the challenges that many state governments face. So as a result of the economic downturn last year with the pandemic, we knew that there would be challenges for state budgets since they didn't have a source of revenue from the taxes that would come in. Typically when that happens, we do know that programs are cut, and the programs that we did not want to cut specifically in the midst of the pandemic were those tied to mental health services delivery. And so expanding financial supports for mental health service delivery, again, during a time where we expected people to be challenged by the psychosocial stressors and other kind of influences of their mental health, important to align and think about kind of funding so that funding cuts would not occur during that time. And actually during the next kind of fiscal budget year. And the next, maybe not as important in terms of California, who has expanded access to Medicaid, but specifically if you looked at the southern states at the time, those who had not been a part of the Medicaid expansion and instances were limiting access to coverage for insurance by placing certain barriers in place, like work requirements and other requirements tied to accessing health insurance. Last year, I think, showed us the importance of the Affordable Care Act and its influence on improving mental health outcomes for communities. And really thinking again about it's important to have fully comprehensive healthcare and one that has a strong and robust coverage for mental health benefits and benefits from the full spectrum. So access to psychiatric services, ensuring that people have access to psychotherapy services, and other kind of community-based resources that also support and sustain their health. And then last but not least is promoting workforce diversity. So being mindful that physicians and other mental health professionals of color tend to return to their communities actually disproportionately. So they're more likely to work in those communities, obviously, than those from others. And so recognizing the challenge that we do see in our mental health professions. In psychiatry, for instance, less than 5% of practicing psychiatrists are African-American, a comparable number or a little bit less for Hispanic Latinx psychiatrists and psychiatrists from indigenous communities, also probably less than 2%. So being mindful that promoting workforce diversity is not only important for practice and professions, but also in recognition of the needs of community members. Oftentimes, patients, and we're well aware, again, of disparities that exist in mental health related to either overdiagnosis of severe mental illness, so overdiagnosis of schizophrenia spectrum disorders in patients of color, or underdiagnosis or undertreatment or disparate treatment for depression and anxiety disorders, or lack of access to psychotherapy services in some instances. We do know that promoting a diverse workforce impacts our profession in a number of different ways in terms of diversifying, ensuring that there is accountability and leadership tied to organized psychiatry and other mental health organizations. And so thinking broadly about strategies to improve diversity. We know there is a problem in terms of the pipeline programs. And so our idea behind this was to create and sustain and augment incentives to create an effective pipeline that would promote workforce diversity. And tied to that again is the importance of taking action. There's a dearth of research that really looks to address mental health equity and support, and a lack of intention kind of behind funding certain programs that are tied to kind of improving mental health equity as well. So this was an important kind of stage for us in the midst of this pandemic as we're all recovering to think a little bit more broadly and intently about ways that we can really achieve true equity in mental health. I'll stop here and hope to be able to answer any questions or to just hear your reactions or response.
I do have a question, Dr. Starks.
Sure.
I know that gender plays a different role in different cultures and community. And I was wondering, in your practice, if you've noticed gender differences to response to the pandemic in the minority group?
Yeah, that's a great question. So I think there definitely are differences there. And I'll point to some of the things that I've seen in my clinical practice. So just as background, I work in a community health center, a federally qualified health center, part of my practice. So we see folks who are uninsured, underinsured, and insured in our clinical practice. In my practice itself, maybe tends to skew a little bit more in terms of seeing maybe more women than men ultimately. What I've noticed in terms of especially those from racial and ethnic minority groups, is there maybe been slightly more economic distress? So people who were unemployed as a result, or who had more financial stresses or strain as a result. We do know, at least certain studies have shown, that there has been an increase in intimate partner violence in the midst of the pandemic. And we also know, again, kind of culturally in some groups, that women seem to take a larger role in organizing and defining the family's kind of kin network. So are more likely to be the primary or main or sole caregiver of children, and also have responsibilities in overseeing the care of their parents. And I do think that has added some extra strain on women impacted by and during the pandemic. And then I also see more broadly, but maybe tied to that as well, is more difficulty in accessing care due to those challenges themselves. So maybe a little bit less engagement overall.
Thank you so much.
So Dr. Starks, I have a question about policy. I don't really know much about it and just what it involves, like the steps that it takes to push for change. But I find that some like the like solutions or changes that you brought up, I wonder if, I feel like some of those kind of are hard to make given like political affiliation and who you're trying to get to like put on their like docket or whatever. So I wonder, do you change the way you communicate like what changes you're trying to make given like which political affiliation you're talking, like which senator, representative, whoever you're trying to get to?
Yeah, absolutely. So it was interesting. So even in editing this particular document, right, like we were, some of the language may have been a little stronger, or some may have perceived it to be politicized in some way. I think the key to think about, because it's just interesting, I think over these past few years, and I guess technically it's probably since the Affordable Care Act passed, is the politicization of health, right? Is healthcare right or not? Who should have access to healthcare and who shouldn't, right? And that slowly changed or evolved over time, right? I think if you probably polled people 20 years ago about whether or not healthcare was a right, you'd probably get different results than you have today. And so sometimes it is important, I think, at least in my engagement with folks who are interested in policy, is to listen to both sides. And sometimes I think sometimes there are things that you shouldn't compromise on, right, in terms of how you communicate it, because there's only one stance. And I think we are living in a day and age where there's a lot of misinformation about health or mental health. But I also think that there are opportunities. So I think that's because of generational changes in terms of how we communicate about mental health, right? This idea that it's much more maybe easier to talk about in your generation. So I think there are changes that do tend to occur and exist as a result. And then I also think when you think about policy, right, you mentioned your lack of attunement to it, or you kind of don't know what it is. I would assume in your medical school, right, like that you've been influencing some policies that occur in terms of the curriculum that's being developed. And part of that's tied to your kind of doing your evaluations perhaps, or maybe other work as a student leader that you see fit. I think keep that in mind when you move to other institutions. So when you are in your training programs at some point in time, when you work for health systems at some point in time, you'll have a say and an understanding about like the local system that you're working in. And then that starts to expand out. So obviously you're working with patients now, you continue to work with patients. And so you'll start to learn about the barriers and challenges that they face in accessing care. And then that may think, wait, well, how is care being delivered here locally or within my state? I think, yes, local politics is easier to change than federal kind of policies and thinking about like, federal fixes for programs. So I do think politics is local, just like you can probably make more changes within your medical school than you can make within the state of California as of yet, but don't kind of diminish your capacity to make change over time. You're already involved in the APA and PsychSIGN, right? And so thinking again about the impacts that you could have as students in terms of your regional PsychSIGN, or thinking broadly about your work that you could do to influence what happens within the APA if you all kind of put all your regions and forces together and reach out to the Division on Education to create more programs for medical students, right? I think you do have some influence in the same way. And again, I know I'm kind of going on and on because I love that question, but I think it's important to figure out how to communicate your intentions, and then to talk to as many people as you can, not just people on your side, but people also on the opposing viewing perspective. I think you'll learn more about how to refine your policy and also refine your message, because a large part of policymaking or influence, I should say, because you may not always be making policy, but advocating for the certain issues is how you communicate your goals and how you communicate your message.
Oh, thank you. I really appreciate that.
I have a question to add on that.
Sure, go.
In regards to the talk in the article and just what happened with COVID, what we just did see that there was a huge increase in community-led movements. Like, for example, I live in LA, there is community fridges, and we see that in Brooklyn, etc. Just community coming together. But it just seems like the politics in America and statewide are always going to be very disbanded, and like everyone has their own, there's not really like a national mandate or something on how to do things. So being someone that works in policy, do you think that we should always work? Like, do you think that the politics of America are always going to be focused on community work instead of expanding that to the national, I don't know how to say it, like national grounds? It just seems like to make change, you always have to work locally, but to streamline things, it seems like it would be easier if we were able to work together with like a national mandate for change. And basically my question is like, do you see us going there with the politics of America right now?
Yeah, I think we're moving, unfortunately, again, just in my short, brief time of exposure to policy, I think we're moving further and further away from national fixes, right? You might have, paid a little bit of attention about what was going on with this reconciliation bill that was tied to, changes in our country's infrastructure, right, versus those kind of social reforms we were trying to make. So I think that's harder and harder to do. And I think that's always been difficult, but I do at least hear from folks who are more experienced that that's more difficult. It's more nimble and flexible to do things kind of locally. And to your point, there is that challenge of kind of community engagement because it should be supported by states and encouraged by states, but oftentimes it's not always, again, easier. So easier in some states than other, right? Like I said, you're in California, and so sometimes you don't have to deal with the challenges perhaps that I have to deal with because everybody in your state should have access to easy access to health services. Now that may be a matter of location or the ease of access to it, right? But here locally where I am, it's a large access since we don't have expansion in Medicaid. But one other point that I was thinking about as you were speaking is thinking about coalition building, right? So how do you get different kind of voices kind of on the same page? And I think that's been an issue and a challenge in mental health broadly. So sometimes you as future psychiatrists, you may not be working, or we may not be working well with our psychologist colleagues because they see mental health from a different lens. And we're not always connected to our social work colleagues because they see it through a different lens. And I think sometimes there is this infighting that occurs. And I think when policymakers, legislators see that, they don't always act on issues tied to mental health because there's very little consensus with our group about what it should look like. And I think that's one challenge that an opportunity, I'll switch my language there. I think that's one opportunity for us who will be and continue to kind of work in mental health is that it's huge, it's segmented. Not everybody knows what it means. Is it psychiatric care? Is it mental health care? Is it behavioral health care, right? Like we have all these different kind of words that we use that sometimes mean one thing to one individual versus one thing to another. And if we're confused about it in the House of Mental Health, how do we expect, the public or the policymakers to really kind of understand our message and our intention behind what we plan to do. So I think that's one thing also for you all to kind of think about in your work, right? Like advocacy and it can happen on a different number of levels. So you have those one-on-one encounters with your patients, their family members, their caregivers, right? You have those interactions with the community, and then you can kind of think more broadly about, your actions with people who are in roles of decision making and can really make meaningful change.
Thank you.
Hi, Dr. Stark. I actually had a question and kind of follow up earlier on kind of what Dan was talking about in terms of, how do we start with policy? How do we start with, kind of getting on that kind of health policy train? I know you mentioned just even now as medical students, when we bring up, changes we want to see in curriculum, or maybe something we want to see the faculty do differently. I know for, especially for medical students, when we're studying all the time, we have to worry about rotations, boards, etc. It can be easy to kind of just be like, I'm already exhausted myself emotionally, physically, mentally to just, succeed as a medical student, let alone be able to take that next step towards advocacy, towards change, towards policy, whether that be for ourselves or for the greater community. So I guess my question would be kind of what are your thoughts on what we can do as medical students now in the future to kind of make sure that we can keep each other accountable to move forward in kind of pushing towards the advocacy for the community, and kind of how do we get around these barriers that might stop us or limit us in our own kind of academic challenges?
That's a good question, and I'll tell you, Ivan, that does not change. It remains the same when you're a resident and fellow, no time. And it'll say the same when you transition to early career and in practice, no time. I dedicate myself to my patients. I don't have time to add other opportunities for that. And I would definitely say that you're already doing it, right? Like the fact that you're a part of PsychSIGN, right? Like you were extending, or created the time and space for yourself to engage for peer mentorship and to get kind of formal mentorship. I think that's one opportunity and avenue because you can't know it all or figure it all out. And so now, as a part of, being a part of PsychSIGN, you have other people, locally in your region and across the country who are, working together. So that's a way of kind of information sharing kind of on one aspect, but it's also a way of kind of organizing in another. So figuring out how you can do this or how this expands to other opportunities to do that. And so a lot of folks engage in organized medicine, whether it's American Medical Student Association, whether it's AMA, whether it's APA, right? Like you get some access to it, right? And you get it condensed, you get on listservs and get newsletters, and so you can get some information there. It sometimes just is a factor of time, right? Like sometimes you can do it and sometimes you can't. I think ways that you can be intentional about it is thinking a little bit about like how you can engage and if we're talking about like true policy is getting maybe to know your state representative a little well. Can you go to your state capitol at some point in time when it's, I'm sure your one is being, well, let's go back. So one, I'll keep you aware of the fact that with PsychSIGN, I'll talk to you a little bit about the APA governance structure, is you all are part, technically, and I can't remember how students are involved, in your district branch or state association, right? You may have a student, or is anybody the student rep for their DBSA? Or know what a DBSA is? I can go over that with you. So no one. So the district branch, you do have it. I think for you all, I'm making it up in my mind, but it could be the Southern California Psychiatric Association, right? You may not know that you have access to that as a student. If you're not already, I'm assuming as PsychSIGN members that you all have to be APA members. Is everybody here a formal APA member? Okay. So it's easy to figure out, and I'll maybe share that with you all later by email. I'll just kind of give you some information, not too much, but just to kind of get you started. So you're part of a larger group that's already doing work in advocacy. It's just figuring out how to connect with them. And so I think that's one way for you to at least learn about it. You may not have time to do it now, right? Like you have priorities in terms of studying, but I think just increase your awareness about who is acting on that thing that I'm frustrated about. I think that's the other thing to think about is like what motivates you to advocate, right? Like oftentimes it's something that makes you upset. So I'll go back and try to put myself back in your shoes back in the day. At my medical school, we were traditional, 2 years of basic sciences, 2 years of clinical services. And so I was first exposed to PsychSIGN in my second year when I had gone to back then it was called the Institute on Psychiatric Services. It's the APA's fall meeting. It was in New York, so it was nice. I received a minority travel award from the APA, so nice fancy trip to stay in a hotel in Times Square in New York was very cool. And then the exposure to all this APA leadership was like tremendous. And so I said to myself in that moment, like, why aren't my classmates learning about psychiatry earlier on? We get no exposure to it until the very tail end of the second year, and that's just too late. Why didn't we learn about it earlier? So started up our own psychiatry interest group. I became a regional leader, got more engaged with the patient advocacy groups like NAMI. And so for me, I was upset about the fact that I wanted to make psychiatry cool, and I felt like some of our students were quite dismissive of like psychiatric care or mental illness and didn't have an understanding. So our intention at that time was just to make psychiatry cool. And, I'd say we did okay. So it went from like 5 people matching the year before to I think 10 people like applying for like our year for the match, right? And so, was it our influence? Maybe, maybe not. Could have just been a transition, but I think that was the initial intention. So it's always behind your like immediate passion in the moment. Then when I transitioned to like fellowship training later on in geriatric psychiatry, I was frustrated about seeing patients, residents of nursing facilities and the fact that they didn't have like good, robust mental health services. They were looked to be depressed and anxious in this environment. And why do nursing facilities have to look like that? So that was my next intention. That made me frustrated and angry. And so I wanted to change it. So one, just think about your interest, think about your time, right? And if you're not doing it, how can you learn about other folks who are doing it? And again, just be a part of that conversation. And that's been my work in the AP more recently. It's not that I have to do it all myself, but I can be a part of the players who are doing it. And so sometimes when I'm frustrated about a situation, I know the people who, you know, are direct the government relations office division of the APA, and I can pick up a phone or shoot them an email, and they can kind of act or respond on my behalf. So I would just say it comes in various stages, various forms, direct grassroots efforts that you can do, the work that you're doing now, informing other people about the things that you see and are concerned about. It can look like anything. You don't have to necessarily run for office.
Okay, that's awesome. That helps a lot. Thank you, Dr. Starks.
And I can take questions on anything, right? Like, yeah, it doesn't necessarily have to be tied to the article or my talk. It can be just about anything in our last few minutes together, so.
I do want to ask how you counsel your patient to advocate for their health.
Yeah, that's a tough one, right? And it's tough because I'm in a system where I have like 20-minute follow-up appointments, right? So it's kind of, it's tough to do. What I will say that I do is I always, and part of this is maybe my background, my mother was a school social worker in New Orleans public school system. So I'm always mindful. One, I've always appreciated every social worker that I've encountered in my education and training and practice. Because they kind of sometimes do the heavy lifting and the heavy work. And so sometimes I try to pretend in my mind that I am a social worker, so somebody who is helping to empower their patients. And so I try to, one, listen very well to my patients, to some of the challenges that they face. So I'm trying to be mindful about like out-of-pocket expenses if I'm prescribing a medication. I'm thinking about their access to insurance. And so I have an idea about like community health centers where health care is delivered. I try to think about like the impacts that they may be facing tied to, you know, transportation access to school, right? So one, I try to be very knowledgeable about like what the system, how the system works and operates. And so when I hear a challenge of a patient and I'm attuned to it, I'll try to, again, give them the education in small bites that might be helpful for them in impacting and changing their behaviors related to it, right? So sometimes I do think you can provide people direct information or resource or number, right? But that doesn't always stick. One thing I will suggest when you are, I don't know how much you're doing that right now, counseling your patients, but I do think when you're in training and you give a patient a resource guide or you give them a telephone number to call, right? Like you should call that number first to know what happens. So if you're calling that number because you are trying to get them transportation services or support, and then you call that number and you realize there's a 6-month wait list, right? Like that's frustrating, right? I didn't know there would be. I just thought I'd give you the number and you connect with the resource and magic, right? But that doesn't always happen. So I will say is to do some of that work, right? Like know what happens when you give someone a call or a guide. One, people may not call or use that thing just because, who's going to pick up the phone and do that? People just don't do that nowadays. But two is just making sure you recognize whatever advice you're giving, you have an expectation about what that outcome is or what it will look like. And that way you can prepare them for it. So I know the list it's a 6-month list. I know it's frustrating, but get your name on it now. And this is who you could contact. So I think sometimes those things are helpful for you. Is just to be very mindful about the system we operate in. Again, I have the fantasy that where you are, it's easier to access things and it's quicker to find a resource than it is here, but I know that is probably just a fantasy and not the reality that you all experience either.
Thank you so much. I really like the idea of calling the number that we're giving and saying what we get back. Thank you so much.
Yeah.
Are there any more questions for Dr. Starks?
Well, cool. Well, I have just a question for you. How many fourth years here? How many folks are in their application process? All right, exciting. Let's see, it's November, so interviews have started technically already, right?
Yeah, middle of interview season right now. So
nice. And how many places are on average? You don't have to give me your number, Isaac, but how many places are people applying to nowadays for?
I think last year the average was 53.
We'll go back again. Is it
last year the average applicant applied to 53 programs, and I think it probably went up this year.
Incredible to think about. So yeah, best of luck to you in that process here. And those of you who are third year, I see some class of 2024 on here. Good luck. Enjoy this time. This is actually the most exciting time. Yeah, after third year, maybe fourth year is, you know, when you get your electives, have more downtime, applying to programs, especially now that the pandemic is. Yeah, glad you weren't that intern class. That was a harrowing experience. So it should be better by the time you all start. But best of luck on your future plans. And again, if anybody has any questions for me at any point in time, I think you're free to share my email address. And I'm happy to respond. So thank you all for the invitation, and great seeing you all.
Thank you so much, Dr. Stark, for joining us today. We really appreciate that.
All right. I'll take care. Bye-bye.
Bye.
Bye. Thank you. All right, so as Dr. Starks was our last speaker, this concludes our Region 6 conference for this year. I really hope you took something away from it. I am just amazed. All the speakers were really great, so I know it was a lot to take in with each separate talk. So I hope you have the time and space to process whatever it is that you need to as who we're going to be as future practitioners and potential psychiatrists as well. So I thank you for your continued support in PsychSIGN. It's just really great to see all of you come out. I hope you have a wonderful day and a really great weekend. Okay, everybody?
Thank you, Dan.
Yeah,
Thank you, Danby. Thank you, everybody.
Thank you.
Bye.
Bye.